Good morning, everyone. We're going to get started. Are we ready to go? Lester, are we good online? Cody? Perfect. All right. Good morning, everyone, and welcome to this meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. I would like to begin the meeting by asking Commissioner Bunch to say a few words in honor of Black History Month.
Thank you, Chair. Thank you for allowing me to open the meeting by acknowledging the significance of Black History Month. As we gather here today, I'm pleased to welcome you to our commission meeting dedicated to honoring Black History Month. This month holds profound significance as we celebrate the Black community's achievements, contributions, and resilience throughout history. The importance of Black History Month transcends mere recognition. It serves as a poignant reminder of the struggles, triumphs, and ongoing journey toward equity and justice. It provides a platform to amplify the voices of those whose stories have been marginalized, misrepresented, or silenced. It's a time to reflect on the profound impact of systemic injustices and the resilience of Black communities in the face of adversity. Moreover, as we convene within the context of mental health advocacy, it's crucial to acknowledge the intersecting challenges faced by Black individuals concerning mental well-being, historically rooted in racism, discrimination, and socioeconomic disparities. These challenges persist today, manifesting in higher rates of mental health disorders, reduced access to care, and stigma within the Black community. Therefore, our commitment to mental health advocacy must inherently intertwine with racial equity and social justice principles. We must actively work to dismantle the systemic barriers that perpetuate disparities in mental health outcomes. We must strive to create inclusive, culturally competent mental health services that meet the unique needs of Black individuals and communities. Let us draw inspiration from the rich tapestry of Black history and continue to forge a path toward a more equitable, compassionate future for generations to come. Thank you, Chair. I'll give it back to you.
Thank you, Commissioner Bunch. At our January 25th Commission meeting, we approved the Commission's strategic plan for 2024 through 2027. Cody, can you please bring up the strategic goal slide? This slide reflects the goals of the Commission's new strategic plan. This plan continues our commitment to advancing the Commission's vision of well-being for all Californians. While the content of our meetings often touch many of the strategic plan's goals, this meeting in particular highlights the goal of championing vision into action to increase public understanding of services that address unmet mental health needs and inspiring innovation and learning to close the gap between what can be done and what must be done. Thank you, Cody. Now we will take roll and establish a quorum. Maureen, can you please take the roll?
Commissioner Bontrager.
Here.
Commissioner Brown. Commissioner Bunch.
Here.
Commissioner Carrillo. Commissioner Carnevale.
Here.
Commissioner Chambers.
Present.
Commissioner Chen.
Present.
Commissioner Chen.
Present.
Commissioner Cortese. Commissioner Danovich. Commissioner Gordon. Commissioner Mitchell.
Present.
Commissioner Robinson.
Here.
Commissioner Rolette.
Present.
Vice Chair Alvarez.
Here.
Chair Madrigal Weiss.
Here.
We have a quorum.
We had a
Thank-
little hiccup with the Zoom audio, so maybe, I think Commissioner Chen is on?
Commissioner Chen? All right, I'll count her as present. We have a quorum.
Thank you, Maureen. We are now moving to Agenda Item 2, Announcements and Updates. The January 25th Commission meeting recording is now available on our website. Yesterday, many of us were able to participate in a tour of the Napa State Hospital and talk to staff and patients about their experiences, which led to incarceration and hospitalization. Connected to the site visit, we have a panel at today's commission meeting that will focus on strengthening early intervention to reduce criminal justice involvement and hospitalization for individuals with mental illness. I would like to invite some of the commissioners who were in attendance at yesterday's site visit to share comments about the experience. Please, Commissioner Chambers.
I just wanted to acknowledge the hard work and person-centered, client-centered approach that I was able to see from the Napa State Hospital executive leadership all the way down to all the line staff. As someone that has been hospitalized involuntarily and voluntarily, what I heard was the state hospital's commitment to community integration and connections. And I want to say on public record that because if we do not have community-based, client-focused, self-determined services, the continuum of care will get stuck in those settings. So I just want to encourage other commissioners to stand in that and us to continue our advocacy relative to building the whole system of care, including our facilities that happen to be locked, but as well as our community settings where those individuals, that where we believe that recovery is possible, that those individuals, maybe not overnight, can thrive and have a full life as determined by themselves. I think that was just overwhelmingly shocking to hear that and amazing and encouraging just to see the importance. And then the workforce piece was important. I think there's a lot of opportunities to work across the system to ensure that individuals that are eligible for community settings also have an opportunity to get viable employment opportunities in, in alignment with their potentially restricted environment in the community setting. So just wanted to acknowledge that, and hopefully if someone from Napa State Hospital is listening, that, I want to lift them up in the work that they're doing. Thank you.
Thank you, Commissioner Chambers. Commissioner Carnevale.
I agree with that and would just add that I thought the most moving part, as always was interacting with the panel of patients at the end of the day. And what became clear, as always, is they're a lot smarter about the system than we are because they all made it very clear that if they had had support early in their life, they wouldn't be there. And so it just, again, points to the need for our system to be more focused on prevention and early intervention, and then a place like the Napa State Hospital would not need to exist. Thank you.
Thank you, Commissioner Carnevale. Please.
Yeah, I echo
Commissioner
the previous comments. I was amazed and astonished by what we saw yesterday, and it's always so moving to hear the personal stories that get people to where they are in life. I was also struck by the focus on staff safety, and so some of the technology that they put in place to make sure that staff is safe, and the staff really did seem engaged. But one of the most impactful things for me as a hospital leader was the comments that the patients made about the time they spend in the emergency departments. And I think we need to be more deliberate in our efforts to create alternatives for site where people have to go when they're in crisis. An emergency department, and I can tell you it's not designed specifically for a patient in mental health crisis. We flex to address it and do our best to keep people safe, but it's not designed for it. The staff are not specifically trained for it, and I think we need to acknowledge that it's an unsafe place. I really want us to lean in and try to come up with alternatives, whether that's crisis stabilization units where first responders can take patients or whatever the venue may be. We certainly can do better to see that so many of them, referenced that part of their care journey was impactful. Thank you.
Thank you, Commissioner Robinson. Did you want to? Commissioner Mitchell, please.
So I thought the visit, I wasn't sure how I was going to feel about it because it wasn't that long ago that my son had spent 9 months there. But there were really good memories of Napa because the Napas are necessary. What I did like was the thought of really sifting through who really needs to be in state hospitals. Community-based services and interventions are very, very important. And so the most needy, the sickest clients or patients should be at facilities like Napa. They do so much. I think we were all impressed with the art, with the healing part of the state hospital. And I can say that everything that they really talked about and illustrated does happen there. They have a very robust family group that I was intimately involved with. Their support systems. I think what struck me when I was attending Napa with my son and the support groups for families to come, you kind of feel like you get an inside view of what goes on and support for your loved one because they have Thanksgiving dinners, Christmas dinners, the families can come in. But I'm always struck by the lack of diversity. And I'm going to always mention it because it's just glaring in the faces of people who look like me. So being part of their family system of care there, very few people of color. Often my husband and I were the only Black parents. Yesterday, when they had clients speak to us, about their experience, which was a beautiful thing to hear their hopes, their dreams, their desires to own businesses and get married, reunite with wives. Again, not one Black patient was on their advocacy panel. Those things bother me because Napa has many Black patients there. So it's like this system of equity and diversion and inclusion, we talk about it, but it just does not seem to materialize in every phase of everything. And so I brought that up to their leadership. And so, I understand explanations, but there are always explanations, but there's still lack of inclusion. Beyond that, it was an absolute beautiful experience for us who do not know what goes on behind the walls of facilities like that because they are necessary. And my son is very stable. They did an amazing job with him. And so I thank them for that service, but I will always ask, in your processing, in your thinking of the work that we do, we have to think about people who do not look like us. It has to be a part of inclusion. Because when people don't see folks who look like them, you don't feel like there's a place for you. And to see that even in that leadership panel of their patients, it was disappointing. But beyond that, it was a beautiful experience.
Thank you, Commissioner Mitchell. Commissioner Roulette, please.
In keeping with the theme regarding interventions in the community, prior to a person experiencing acute distress that might result in them being hospitalized at Napa, and having had several occasions in my career to visit Napa State Hospital, I certainly, Toby, and to the staff would offer, if there was a opportunity to see the other part of the continuum, and that includes behavioral health urgent care, respite services, and then crisis residential. And again, a lot of those services have included in them a very important component of people with their own lived experience, family members, and a unique diversity that is oftentimes easily or easier to achieve in a community-based setting than it is sometimes in a state hospital. And I don't mean that in a disparaging way. The workforce issues that we all experience are real and especially acute right now. So Toby, I want to make sure that that's presented as the next part of this conversation related to the community-based alternatives that are designed to ameliorate distress prior to a person going to a state hospital. And as Commissioner Robinson said, also designed more aptly to provide support versus an emergency room. And that's not to disparage emergency rooms. They have a very important role in the continuum of healthcare, but in the continuum of behavioral health care, there are urgent care clinics that are specifically designed to provide those supports and services.
Thank you, Commissioner Rolette. Thank you, everyone, for your comments. Commissioner Mitchell, I agree wholeheartedly. I think that was my first questions. What are the demographics? And we were specifically around race, ethnicity. And that was not a no number, which I thought, how do we not know that when it's something that we constantly are bringing up? And yet when you look at our jails and you look at our prisons, they are very much those people that look like you and me. And so it is a concern. I think we need to continue to lift that conversation up. When speaking to the patients, almost every story began in their early youth. So I think it does speak to how we need to talk about prevention, get information out there to our young as well. And when we brought up the conversation around peers, if that's, peer programming in our schools, but of course peer programming in our communities, how that could have made a difference. And a resounding, absolutely, that could have made a difference. So things that we need to consider as we move forward. So I want to thank the staff that put together this site visit. Excellent job. Thank you for informing us of what we would see, what to look for, and just, it was an excellent site visit. So I want to thank you for putting that together. Excellent job. Thank you. And definitely the staff present at the hospital. They were very accommodating and did a wonderful job, I think, taking us through the site visit. So thank you, everybody. In the past, the commission has had standing committees made up of 15 members to provide advice and guidance to the full commission. The role of the committees is to advise the commission on specific subject areas related to its various projects and initiatives. The strategic plan provides an opportunity to ensure that the committees have a well-defined role and a specific technical advisory task. The areas of focus of the CLCC and CFLC will align with the 2024-2027 strategic plan goals and objectives. Beginning this year, the CLCC and the CFLC meetings will be held on a quarterly basis, and the committees will update the commission on the implementation of the strategic plan goals and objectives, and will advise the commission on overcoming barriers we may face with implementation of the plan. I would like to announce that I am reappointing Commissioner Mayra Alvarez as chair for the CLCC and appointing Commissioner Rachel Chambers as the chair of the CFLC committee. Commissioner Alvarez and Commissioner Chambers will make recommendations on vice chair appointments. We look forward to hearing from our committee members in the coming months. As you may have read in the Transformational Change Report released last month, the Commission is excited to announce the launch of an interactive community engagement map now live on our website. Cody, can you please bring up the impact map on the website? At our January meeting, we discussed the vital role of community engagement in our work. This tool directly ties to our strategic goal plan of championing vision into action and relentlessly driving expectation. It highlights the areas throughout the state where voices are being heard and at the same time revealing the areas where we need to expand our outreach efforts. The MAPS filters allow you to view past and upcoming in-person and virtual events and includes everything from commission-hosted events like site visits, committee meetings, and listening sessions, to events offered by various commission grantees representing diverse racial and ethnic communities, K-12 students, LGBTQ+ communities, veteran groups, and more. Staff is already working on Phase 2 enhancements to the tool, and we encourage everyone to check it out on our site as we continue to evolve both features and functionality over time. Again, I want to welcome everyone again to today's meeting. The plan is to end around 3:30. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the commission staff can make you a co-host again. It is now time for Agenda Item 3, General Public Comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during general public comment time. If you have any technical questions, please contact Commission staff at 916-500-0577. At this time, I will ask Lester to go over the public comment procedures.
Thank you, Chair. All members of the public will have the opportunity to offer comment as described in the agenda. If you'd like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order that they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. And Chair, I hand it back to you.
Thank you, Lester. Would you please open the line for general public comment?
So we have 2 public comments in the room, and we have 2 online. We'll start with the in-person comments. June Lee, please go ahead and make your comment.
Hi, my name is June Lee. I'm the Executive Director of the Korean Community Center in East Bay, serving immigrants and refugees with limited English proficiency. Our model is community mental health, meaning that wraparound service for individuals to go through their journey of immigration and then stress points. So basically, as you mentioned in your announcement, we interfere, we kind of provide a service in every important moment of their life, from childhood, and then when they get stress point, like going to school, get a bad grades, or get a new job, or get fired, and so all those preventive matters that we interfere with. So, and then at a personal level, I'm also, some of my family members are consumers. At the same time, I lived as a wife of a research psychiatrist for 25 years. And then he's also very grounded in community, from serving the locked facility like Napa or John George in Alameda County to more of a, top-of-the-notch technology-based, evidence-based practices like, TMS and other device-based treatment. So I'm very well aware of the whole plethora of the mental health treatment, as well as a community who is just suffering from, a lot of different moments in their life. And then I'm very glad to be here. This is my first time, so I just wanted to briefly introduce myself. Thank you.
Thank you, Junlee, and welcome.
Great. Next, we have Stacy Hiramoto. Please go ahead.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I want to thank you, Chair, for talking about the CFLC and the CLCC. Those, I feel, are the most important committees, or among the most important committees that you have. And I urge you that if Prop 1 passes, that you also utilize these committees to advise you in the planning. Even though if Prop 1 passes, it is not the same as Prop 63. I hope we still will hold on to the principles of involving the community and consumers and family members and, again, people from underserved communities in your plans. So please don't leave them out, or please don't leave the public out when you begin to plan. And thank you. And if there are appointments that are absent, if you could also make sure that those are filled, because I know there's some confusion about, whether the people from the last time are being reappointed. So if that could just be made clear, and if we need to replenish some of the members, if you could just make that announcement. Thank you.
Thank you, Stacy.
We have one more in-person public comment. Patricia, please go ahead.
Good morning. My name is Patricia Sullivan. I'm on the Napa County Mental Health Board. I'm currently the vice chair. I'm a consumer who've been hospitalized many times over the years, and an advocate for the last 30 years. And when you're talking about using crisis centers, I want to definitely encourage the use of physical emergency medicine first before going to a crisis center or immediately in the entering process to a facility, because I've talked to many people who have not gotten their proper physical medicine, lack of insulin, to the point that they go into crisis and have to be hospitalized in a physical hospital for physical medicine and other physical medicine needs. Thank you.
Thank you, Patricia.
All right, we have 3 public comments on Zoom. Richard Gallo, your line is open. Please go ahead. Okay, Richard, you should be able to unmute. Okay, we will return to Richard. Dakota Brown, your line is open. Please go ahead.
Hi there. Thank you so much. I have a comment about the Riverside County Innovation proposal, and I don't know if I should do that now or wait till you get to that agenda item.
We will have public comment for that specific agenda item, Dakota.
Thank you. Thank you so much. Bye.
Next, we have Graciela. Your line is open. Please go ahead.
Graciela Van Wormer, right?
Yes, I'm sorry. Please go ahead.
Okay, good morning. I'm Graciela, mother of Sheila Van Wormer, who is hospitalized in Napa State Hospital. She has been there for 6 months. I'm seeking for a setting in a different hospital where my daughter can obtain a greater support. Because right now, she's unhappy, not healthy, and she's not getting the proper treatment. I got information about today's meeting from someone of Orange County Mental Health Board. He believes that you are the organization that will assist me. Is that correct? I have a lot of I have a lot of challenges communicating with personnel from Napa Hospital. They are either not working, on vacation, or they just don't answer my phone calls or reply my text message, my email messages. It's not that I want information. I'm almost done. It's not that I want information from they breaking my daughter's confidentiality. I want to talk to them about someone from their care team that will assist my daughter, because 5 things: she's not having enough food, and no, she is cold all the time. I have visited my daughter like 5 times because I'm from Orange County. She is in constant pain because either she doesn't eat, she's very cold, and she's not sleeping because they took away her medication. And I can continue going on.
Graciela, I'm going to ask that you send an email to the general email of the commission, and staff is going to make contact with you.
I emailed all the documents yesterday because unfortunately
To the general, okay, to the general email of the commission?
Yes, the one that appears in your agenda on page 5.
Is that the one? Then I will make sure that staff reaches out to you.
Thank you very much.
Thank you, Graciela.
Okay, we're going to return to Richard Gallo. Richard Gallo, your line is open. Please go ahead. Richard Gallo, you should be able to unmute. Okay, we're going to go to our last public comment. Teslim, your line is open. Please go ahead.
Great. Thanks so much. A pleasure to be here with you all commissioners and the general public. My name is Teslim Ikaro. I'm Executive Director of Supportive Housing Community Land Alliance, a community land trust based in Alameda County. I am just here to kind of provide an update on our project and one of the important pieces of a program that we just launched a few months ago, which was a micro grant for licensed residential care facilities in Alameda County, providing support to operators to improve quality of life for residents. We're a land trust intended to create 2 models. One is a family partnership where family members can co-invest together to create a safe place for their adult children. And the other is, ensuring that boarding cares, we can increase the quality and the number of boarding cares across Alameda County. As you all know, boarding cares are closing across the state at rapid pace, and without this important piece of the housing continuum, we won't be able to actually address homelessness and mental health issues sufficiently. And so we're at an inflection point in our organization. We're hiring a number of staff members and also recruiting a number of board members. Want to make out a general call to individuals who might be interested in participating in our organization as either board members or if there are a diverse number of individuals interested in positions. We're hiring for a director of real estate development and a director of programs and social impact. So just wanted to introduce myself and glad to be here with this group, and appreciate all the work being done to improve the continuum of care.
Thank you, Teslim.
And that's our final public comment.
Thank you, Lester. Thank you, everyone, for your comments. The commission will now move on to agenda item 4 and consider approval of the minutes from the January 25th commission meeting. At this time, I would like to invite commissioners to offer comments or ask questions. Please, Commissioner Chambers.
Thank you. I just wanted to get a point of clarification, I think on page, sorry, I'm looking for my minutes, on page 28. The last meeting, it was noted that I had asked, while a discussion about Prop 1, and it was clarity provided, I'm trying to read the exact statement. Commissioner Chambers asked if staff will review legislative analyst report and findings relative to Prop 1 at the next commission meeting. Ms. Dollar stated that the outcome from Proposition 1 will not be known until March. Commissioner Chambers stated that the commission had not had a discussion on Prop 1. Executive Director Toby Ewan stated that the commission is not allowed under the state's rules to use public dollars to advocate. The commission can inform, but the commission has deferred to Cal HSS and the legislative analysts who inform because they have a greater capacity to answer questions about Prop 1. I also just wanted to clarify that my statement was never about advocacy. So I just want to get that on record, that I was not trying to do that. I've just had a number of the client and family representatives that I represent, that I was appointed to, and as an officer of the state, I am also wanting to make sure there's opportunity for education and empowerment so that people can just understand. So if it's access to voter guides, where there's non-biased or nonpartisan information, I feel like it's important in every avenue and aspect of like oversight and accountability of any capacity to provide education and access to it. So I just want to put that on record, that I was not asking that question to advocate. That was it. I don't know if that needs to be corrected because it was just interpreted as advocacy, and that's not what I was intending.
Thank you, Commissioner Chambers. Okay, so we have that on record now. Thank you, Commissioner Chambers. Are there any other comments or questions regarding the minutes from commissioners? Okay, seeing none. At this time, members of the public may request to make a public comment on Agenda Item 4 by clicking the Raise Hand button on your computer or the app, or if calling in by phone, pushing *9. Lester, are there any public comments? Please raise your hand now as the queue will be closing.
Chair, there are no public comments.
Thank you. So at this time, oh, Lester, I think there's one that just,
Yes. Dakota Brown, your line is open. Please go ahead.
You want me to respond to agenda item 5, correct?
no, we're not quite there yet.
Okay, thank you. Sorry.
That's okay.
And that would be our last public comment, Chair.
Thank you. Then I would, at this time, ask for a motion that the commission approves the January 25th commission meeting minutes.
So moved.
Thank you, Commissioner Robinson. Do I have a second?
Second.
Thank you, Vice Chair Alvarez. We have a motion and a second to approve the January meeting minutes. Are there any additional questions or comments from commissioners? Seeing none, I would ask then that Maureen please take the roll.
Yes. Commissioner Bontrager,
Abstain.
Commissioner Brown, Commissioner Bunch,
Approve.
Commissioner Cannavale,
Approve.
Commissioner Carrillo, Commissioner Chambers,
Approve.
Commissioner Chen,
Approve.
Commissioner Cortese, Commissioner Danovich, Commissioner Gordon, Commissioner Mitchell, Commissioner Robinson,
Approved.
Commissioner Rolette, Vice Chair Alvarez,
Aye.
Chair Madrigal-Weiss.
Approve.
The motion carries.
Thank you, Maureen. Let's move on to our next agenda item. We will now move on to Agenda Item 5, the items calendared for consent, which includes the approval of an innovation project, Riverside County, and relocation of Alcove Youth Drop-In Center funds. Commission staff have sent the documents related to these items to all commissioners, and a copy of the staff analysis for the Riverside Innovation Project has been provided in your packet, sorry. The Riverside Innovation Project had a significant amount of community engagement, not only at the local level, but also through the commission's process, which is outlined in the document in your packets. The innovation project was shared on December 6th of last year and again on January 24th, 2024, with community partners. No comments were received in response to the commission's request for feedback for this project. The innovation proposal included 7 letters of support from community partners for this project. The other portion of this consent item is related to the reallocation of $2 million set aside for Alcove. In January of 2020, the Commission approved an RFA and authorized 5 contracts each in the amount of $2 million to the awarded organizations. 6 applications were received for the 5 awards. However, one of these applicants were unable to incorporate all of the Alcove components and could not continue as an Alcove grantee. The $2 million award was offered to the next highest scoring applicant as allowed in the RFA. The next highest scoring applicant turned down the funds due to the staffing challenges. Staff is recommending that the remaining $2 million be reallocated to the existing 4 grantees to allow them to expand their programs. As a reminder, any commissioner can remove an item from the consent calendar. That item would then be considered as a regularly scheduled agenda item at a future commission meeting. At this time, I would like to invite commissioners to offer comments or ask questions. Please, Commissioner Bunch.
I have a question about the eating disorder program. In reading it, one of the second components, the second component has utilizing cultural competency. And I was just wondering if there's anyone available to say more about what they mean by utilizing cultural competency, particularly for this population.
Thank you. Toby?
So the way the consent calendar is set up, that if you want to have a discussion on the item, then we need to table it and bring it back at a future date, right? So, and that's fine, right? That's just part of the process. So, you know, there's no challenge in terms of setting that aside, right? We did not arrange for the advocates for the program to come and be able to respond to questions because there were no public comments or questions. So that's how the consent is designed.
If I don't want to delay it, is it possible to just get that information offline?
You can certainly, at any time, any commissioner can ask staff to follow up for details regarding any this program or any program. And so if that's not material to the vote on the item, then it's not, you know, wouldn't suggest that it delay the vote. And absolutely, we'd be happy to follow up with the project organizers to answer any questions you have.
Okay, so I'll put the question in writing and email it.
You got it. Thank you.
Any other questions or comments from commissioners? Okay, seeing none, then at this time, members of the public may request to make a public comment on agenda item 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Are there any public comments, Lester? Please raise your hand now as the queue will be closing.
We have 2 public comments online. Amy Meyer, your line is open. Please go ahead.
Good morning. My name is Amy Meyer. I'm a licensed clinical social worker and a manager at Inland Empire Health Plan. I'm here as a representative of IHP to speak in support of Riverside County's innovation proposal for the Eating Disorder Intensive Outpatient and Training Program. I have the honor of being the manager of IHP's Eating Disorder Team, which has a unique collaborative relationship with Riverside Behavioral Health. This partnership is the envy of others, as evidenced by the other county behavioral health agencies reaching out to IHP and Riverside Behavioral Health to learn about this partnership to mirror our processes and workflows. IHP and Riverside Behavioral Health meet weekly to discuss our shared members identified with having an eating disorder diagnosis. The goal of these meetings is to determine the most appropriate level of care for this vulnerable population, whether that care is outpatient talk therapy or within a residential treatment center. The approval of this proposal would get access to a therapeutic intervention provided through an IOP program and allow the ability to effectively coordinate individuals to the appropriate level of services, whether they are stepping up into more intensive services or moving down that continuum of care. As we all know, there's been an increase in the number of individuals diagnosed with an eating disorder, disproportionately affecting our youth, especially since the pandemic, leaving a need for more providers specific to this diagnosis. This proposal addresses that need and focuses on education and prevention within our community. To end, support of this proposal reflects IHP mission and vision to heal and inspire the human spirit and not to rest until all of our communities enjoy optimal care and vibrant health. IHP would like to thank the Commission for their time.
Thank you, Amy.
All right, next we have Dakota Brown. Your line is open. Please go ahead.
Thank you. And thank you for tolerating my enthusiasm today. I communicate with captions. I'm using those for accessibility. Dakota Brown, I use she, her, they pronouns. I identify as disabled. I carry behavioral health diagnoses of depression and eating disorder. And I have a hearing disability. And I just want to thank you for letting me speak briefly. I worked for Riverside University Health System Behavioral Health as a peer support specialist before I took on my current role as a cultural community liaison to people with disabilities. And I have been so pleased to see that the intensive outpatient project that our UHSBH is proposing has brought in all our cultural liaisons to advise it from the start. And we haven't been brought in as an afterthought. You know, it's no good to have the diversity, equity, inclusivity, accessibility just be something we talk about, or, you know, let's have our DEI people over here to say we fulfilled our DEI requirements. That's just the performative allyship. Cultural competence has to be woven within and scattered throughout all of our county services, our platforms, our administration, and our clinics. You know, California is so great at leading the rest of the country in social policy and justice and human rights. And this is just another opportunity to be the vanguard and model what it means to care about the most vulnerable of our citizens. So just please consider moving this revolutionary project forward. And thank you so much for letting me speak today.
Thank you, Dakota.
Chair, we have one more comment. Sarah Robin, your line is open. Please go ahead.
Hi, good morning, everyone. I want to vouch my support for the Innovations Project for Riverside County. I've been a clinician for eating disorders for some time now, and something that separates this project from others is their ability to fill different gaps of care in providing services for this population. Eating disorders have the highest mortality rate across all mental illness, aside from the opioid epidemic that we're experiencing. And that's mostly due to both the mental health and medical aspects of these disorders. And so I strongly believe that having an IOP will not only prevent the need for higher levels of care through both medical and psychiatric hospitalizations, but it'll give us an opportunity to do intervention, outreach, educate, doctors, clinicians, allied professionals, because many of these disorders are overlooked and they actually don't come to fruition until they become hospitalized. So I think this program, especially being in the most significantly underserved areas of Riverside County, will continue to fill those gaps and those disparities, mostly because many of the people who live in Riverside County are, economically a challenge, and there's a lot of systemic barriers to getting the care that they need. And so I just wanted to take a moment to give my support for this project as a clinician and as a community advocate. Thank you.
Thank you, Sarah.
And Chair, that was our last public comment.
Thank you, Lester. Now that public comment has closed, I would entertain a motion that the commission approves the consent calendar that includes funding for Riverside County's Eating Disorder Intensive Outpatient and Training Program Innovation Project and the reallocation of the $2 million of Alcove Youth Drop-In Center funding to expand existing Alcove programs.
So moved.
Thank you, Commissioner Mitchell. And do I have a second?
Second.
Thank you, Commissioner Carnevale. We have a motion and a second to approve consent calendar items. Are there any additional questions or comments from commissioners? Seeing none, I would ask then, Maureen, that you please call roll.
Yes. Commissioner Bontrager.
Aye.
Commissioner Brown. Commissioner Bunch. Commissioner Carnevale.
Yes.
Commissioner Carrillo. Commissioner Chambers.
Abstain.
Commissioner Chen.
Aye.
Commissioner Cortese. Commissioner Danovich. Commissioner Gordon. Commissioner Mitchell.
Approved.
Commissioner Robinson.
Approved.
Commissioner Rolette.
Approved.
Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Approved.
The motion carries.
Thank you, Maureen. Let's move on to our next item on the agenda. For agenda item 6, we will be hearing from a panel consistent with Commission's new adopted strategic plan goals and the alignment with yesterday's site visit to Napa State Hospital. The Commission will hear a panel presentation on early interventions to reduce criminal justice involvement for individuals with mental illness. We will hear from Tom Orrick, Deputy Director at the Commission, who will provide some opening remarks before we hear from our presenters.
Thank you, Chair Madrigal-Weiss, Vice Chair Alvarez, and Commissioners. One of the goals of the Mental Health Services Act is to prevent negative outcomes associated with unaddressed or untreated mental health needs. This panel today will provide insight on early intervention opportunities that can serve to divert a person away from negative outcomes, such as juvenile justice involvement, arrest, incarceration, hospitalization. You'll hear about some of the early warning signs of struggle in the lives of those who end up in our downstream systems of care, such as the Napa State Hospital. The state spends billions of dollars treating individuals with mental illness who have committed crimes. The 2023 Department of State Hospital budget is $3.5 billion. California Department of Corrections Rehabilitation, $14.5 billion. Cost over $100,000 to treat one inmate for the year in our CDCR system. According to the Council on Criminal Justice and Behavioral Health, there are 14,000 minors detained each day in the county-run juvenile detention facilities. And 90% of these youth have experienced, of course, a trauma or significant trauma or toxic stress. 88% of those youth are Black or Latino. I share this information to set up the question, can we do better to provide services earlier on in a person's life? And if so, if we can, what steps should be taken? What systems should receive our full focus and attention to ensure that all Californians have a chance to thrive and live successfully in their communities? So we had hoped to start our discussion with both a consumer and a family member, but unfortunately Lamar Mitchell was not able to join us today. However, at yesterday's site visit, the Commission received a one-page document, a description really of a patient's experience prior to incarceration that was written by two Napa State Hospital residents. Their letter was provided to you and put it into your packet because we just got it yesterday. So you have that in your packet. So to begin our panel discussion, I'd like to introduce you to Sheila Robinson, who will share her experiences from a parent's perspective. Sheila is accompanied here today with her support person from NAMI, Sonoma County, Mary Frances Walsh. We will have Sheila share her thoughts, and then we'll bring up the other panel members when she has shared her perspective. Sheila, thank you for being here today. It's been great to meet you and talk with you as we've prepared for this. Please tell us about your son. And I know you shared a lot with us about his greatest qualities, so I'd love to hear about that. When mental health challenges surfaced for him, and your experience in advocating to get him the help that he needs.
Excellent.
Thank you for being here.
Thank you, Tom, very much.
You can turn that on.
Oh, is it on?
Yeah, we'll punch it on there for you. There you go.
Oh, thank you. Thank you, Tom. Thank you for having me to come and share with you. We might have a little change of pace here. My lived experience is ongoing. My son is currently incarcerated in the main detention facility in Sonoma County. My name is Sheila Robinson. Thank you for inviting me to speak. And I wanted to say I'm reminded of the metaphor of putting a message in a bottle. That's how I feel. And waiting for a strong outgoing tide. And I wanted to also say something about the way this story gets expressed by family members that I see all the time in my NAMI support groups. Also in Al-Anon. Al-Anon is a good source of support. I'd like to express that those of us who are currently involved are having, involved with our loved ones that still have them in our life, are always feeling a state of crisis. And there might be tears, and I don't have any tissues, but.
We'll get you some.
But you understand, I know you do. I'd like to tell you a little bit about Nico then, and myself. I'm a 28-year resident of Sonoma County, Santa Rosa, a college graduate, a retired blood banker, and the mother of 4 adult children. Nico, my youngest, is 35 years old. He has lived since he was 22 with the sudden diagnosis of schizoaffective disorder with bipolar highlights added in at times. And as of his last hospitalization in 2022, psychotic disorder now. He has lived with me all his life, except about 3 years, during which time he was unfortunately asked to leave 2 housing programs and then company housing, which led to the loss of the job. That was at Mammoth Mountain. He was a ski lift operator. He loved it. It was very good for him, but unfortunately I didn't realize that Mammoth Mountain's workforce is entirely young, entirely from around the world, and entirely into marijuana. As we'll find out later, marijuana is my son's trigger. My son's life and my own have been very deeply affected by the challenges that have come with his mental illness, an illness that has never received the kind of care that I know is out there. Thank you. Thank you. This is all good. Because if we can't talk about it, it really becomes impossible. I feel he deserves, as an ill person, he deserves better care. Everybody's trying so much. Let me just insert right here. All systems seem to be impacted. Everybody's trying, but we need to go to that next step, I strongly feel. He was once seeking help for about the first 5 of those 13 years. He was compliant. He doted on his nieces and nephews when he'd see them. He worked staffing agency jobs And he continued to love skateboarding, snowboarding, and photography during that time. He was taking medication, and he was in a large social milieu with his jobs and his hobbies. Patient-centered, multi-approach, comprehensive care might today have given him a life of dignity and hope, instead of a chaotic life, estranged from family, spent in 5 hospitalizations and 3 incarcerations, waiting for often delayed evaluations, waiting for qualified people to evaluate while incarcerated to determine eligibility for diversion, eligibility for mandatory medication, degree of disablement, and of course, competency to stand trial. And then the resulting days waiting to get a bed in an incarcerated competency restoration program. And I'll give more about the justice piece after going through. I want to stop right here and say that so many parents of seriously mentally ill children that I know are not able to process it all. We throw it in a box. We can't deal with it. We go to the box to try and organize it and get an overview. I'm a big picture person. I really need to, I can see what's happening better when I see everything. I haven't been able to do it for 13 years. Of course, I have been busy as well, working full time and going to school for part of that. But it's so difficult it's emotional. You take out the papers and then have to put them back because so much of it is a failure, a disconnect. Nobody's fault again. We're just not quite there yet. So having this opportunity made me get into some of the boxes, and I'm starting to organize it. Thank you so much. Really, so important. So important. And I've been seeing patterns these last few days that I'd like to share. The reasons why at certain points he fell through the cracks. Okay, so 13 years, the last 13 years, he just had his 35th birthday. Childhood, 1989 to 2010. Then his initial break was 2011. And he had a period of pretty much stability for 5 years of compliance with everything. It wasn't just medication compliance. So that was until 2016. But then something happened in 2016. He lost my Kaiser coverage, which was through my job. And so things started to break down a little bit before we were trying to reconnect again with the medical system. And it was rocky there. I'll go into a little more detail. So that was 2017 to 2019 for a very confusing middle time, that transition from insurance. And in that time, there were some more hospitalizations, definitely, during that time. And then COVID came, and that is the last piece. That I call it COVID and growing non-acceptance of consensual reality. And that was 2020 to 2024. So he's been unmedicated for the last 4 years, living with me. The end of the confusing middle years, 2019, he was incarcerated with his first big incarceration. And that lasted 9 months from beginning until he reached competency. And at that time, the 2 felonies, one was dropped because he didn't do it. They looked at the officer cam. And number 2, they reduced the second one to a misdemeanor with no oversight, no program, nothing. So he came home to me. I've always felt that he would not survive on the street because he is very against drugs. He's sort of a purist. He put himself on a vegan diet and is so strict with it, he would throw out my food when I wasn't home because he's so adamant. Once he wrote on a carton of eggs, he just left the carton for me, and he wrote on it, "These mother chickens are crying." So, oh, thank you so much. So, I want to reconnect now with the timeline here. So you might wonder, I can share a couple things of what it was like. There were some points during that 4 years where I began to adjust to his mental illness, and I learned how to talk to him very early, and I learned how we could get along, and it was all about relating and emotions and being there, open, so that trying to be transparent. So, okay. I'd like to go back to section 1. Nico, my 4th child, was born 7 years after my 3rd child, right after I'd quit my teaching assistant job to commute to college full-time and finish my BA. He went with me to class in utero and as an infant, intellectually very stimulating. At times I've wondered if he was affected because I was constantly in a state of ecstatic learning and thinking about my papers I was writing and the information I was getting. He was definitely an observant child. Overall, his early childhood and youth were relatively normal. Nothing strikingly out of normal. Through his early childhood, he was sometimes upset by images of violence. I'm sure many children are, some more than others. He was very upset. Until he was 18 months old, we lived in a rural setting with no television. I can remember when we moved into Clear Lake and he'd watch TV with his siblings, his older siblings. He once said at age 4 that it made him sad to see people killing people on TV. What shows were that I was letting my kids watch? Oh yes, a wide swath of classic primetime entertainment when you look at it from an outside perspective. That was one of my points that I was really going to be heavy about, and then I decided, we all know that. We all know that the reality that we've built around us, our culture, our dominant culture, maybe has contributed a little bit to our current state of crisis in some areas. One time playing soccer at age 7, he ignored the ball that was kicked right to him in front of the goal, and instead he turned and helped up an opposing player who had fallen hard. And we'd moved to Santa Rosa by that time, the kids and I. Our marriage was breaking up. My husband wanted to stay on the land where we had raised the kids, the older kids, and he was adamant. He couldn't understand my need to get closer to more infrastructure. It was a challenge. It was hard. We still respected and loved each other very much, but I needed to take my children closer to good jobs, education opportunities, and friends. But he had a heart for people, but he was, I would characterize his relationships with his siblings as close to his sisters because they helped him as a baby when I was at school, night school, and as he was an imp to his brother. They never, their age gap was such that they never really got to the point where they're close in adult years, which it would be so wonderful if that would change, could change, but it can't change at this point. We know that. He did well in school when he wanted to. And he was nominated for Summer Search, a leadership program for high school students, but he was not chosen. He began doing less well as a student in high school, however. Doing well seemed to depend on whether he liked the teacher. And again, we have the same theme of relationships, which will come around to our bigger picture, and I've already heard it this morning here about the need for people being together, relationships. He still had a close group of friends from middle school through high school at that time. And I wanted to share that the pictures that I brought, I wanted to show how many people are affected. And this is not all of them. The pictures from my Alabama family came too late to include. But these are the people that are affected when one person is untreated because of a system that has just too many cracks right now. Just a little bit too many cracks. So I know that's our job. I'm so committed to spreading the word about filling those cracks. I'm so committed. In high school, he did sustain an interest in astral travel. That was very curious to me. He'd read about it and he was fascinated. So I wanted to share that in case anybody is trying to find a causal relationship. I started to look at what I could do myself to get to the bottom of this, and I'll just read a fast list. Explore whether my amniocentesis could have had an effect. It was a very difficult birth. Big gap in the siblings' ages. Separation of my husband and I, bad concussion at 18 months, horrific. I mean, he fell 3 feet on his forehead and needed stitches and some downtime. Too many video games from 2 years on. A toxic water well in 6th grade that they had to close down because chemicals from the vineyards had seeped in. And the water at the school could no longer meet the standards. So to this day, it looks like they still have an outside water supply. And the curious thing is that one other child in his class also got diagnosed with schizoaffective disorder. But it was in his early 20s as well, which, is a common age. So that's just something to think about. He had numerous head injuries, skateboarding, numerous. And you know the credo there is to not wear a helmet, really. Even though I would beg him and get angry and try and buy him off, it didn't help. He began getting cystic nodules of acne, big time, on his back. And so he had 2 series of Sotret, Accutane, isotrianon, I believe, Tretinon. And that stuff is very strong. And I did read an American Psychiatric Association report that they had done some imaging studies and found a depression of the messages getting through to the frontal cortex, I believe. And the thing is, the doctor his psychiatrist at Kaiser just said, oh no, that would have only been at the time when he's taking it. But I don't know. We could look into it. Deep family emotional trauma, which could have been the kicking off trauma. It happened when he, in 2009, we were a household of 4 and we lost 2 family members within 30 days. That was very traumatic, of course, as you can imagine. We've all had losses, and loss can throw you for years. But do we want to be wise or do we want to be wounded? We want to be strong and work through this, right? Marijuana use triggered probably 3 out of his 5 hospitalizations. And then an interesting study out of New Zealand Now, as you might know, New Zealand and Australia are coming up with, are really tackling their mental health system right now. They found, there's a study that says that living within 300 feet of a major traffic artery increased the chances noticeably that there would be some kind of mental illness in that population, higher than normal. And we always did. Once we moved to Clear Lake and then Santa Rosa, most of the time we were living right close to the arteries. So that's that.
Sheila, we have probably a few minutes left, but I want to make sure we can shift to have you tell us about some of the frustrations that you experienced seeking help.
Okay.
What's been the most difficult thing for you as a parent to get the help? It sounds like there were many attempts. The system missed opportunities to help him. But what was most difficult
Okay.
in seeking help?
All right. Very good. I'd like to read his, to that end, I would like to read just a description of the very first initial psychotic break. That is the very first sign that anything was off that I had ever had. At age 22 in 2011, he had an episode that may have been a prequel to his illness. When I came home from work, he was waiting for me in the parking lot. Very unusual. Mom, the neighbors don't want me here. When asked why he would think that, he insisted I can hear their thoughts. He was clearly upset and disturbed, and I had never seen him like this. So suffice it to say, we went to the Kaiser Emergency Department, and after a wait of a couple hours, he was still covered under my Kaiser, my work insurance. The psychiatrist came in and was very breezy, and it was very noisy there and stressful for my son. And it was an open cubicle, and the on-call psychiatrist did nothing to calm him down, give him perspective, nor explain that this might be related to an illness. Instead, he laughingly dismissed my son, Nico, for having smoked some weed and sent him home as if it were nothing important. For the next several weeks, it brings back really bad memories. Because you can't understand that this is really happening to your son or yourself. For the next several weeks, he continued experiencing thoughts that made him very uncomfortable. So I arranged for him to be seen at Kaiser by a mental health professional. This is very important to share because this was the best experience of the last 13 years. Kaiser was very insightful. They gave him psychiatrist medication management appointments after he came back from Telecare in Oakland. Telecare Heritage Psychiatric Facility was where he was sent after a few weeks. He just couldn't take it. It was really bothering him. This was continuing. Obviously, it wasn't just the marijuana, but it had triggered something. Maybe there's a mechanism there. So I arranged for him to be seen by a Kaiser mental health professional who he was asked if he wanted to find out what was happening to him, and he said yes. So they found a place down at Telecare. He was there for about 7 days. When we visited, and after he came home, he couldn't stay awake. They over-medicated him so tremendously, and as you may know, they don't do that anymore. When there's a marijuana-induced psychosis, especially in young people, first time they let them come down and let the marijuana wear off and then see where they're at, then do their evaluation. So I think that's very wise. We'll never know. He was on 3 medications, and when we came back home and he saw his psychiatrist, he adjusted his medication immediately, which was really good. And Nico brightened up a little. He did 10 talk therapy sessions, which were really good for him. But then he started saying that she was more like a girlfriend and he was uncomfortable. So he stopped. He was referred to group at Kaiser. And that was okay, but they asked him to leave when he somersaulted into the middle of the group when he came in. So he was asked to leave. But he was pretty busy. Again, this is his compliant time. He kept busy with a lot of jobs and hobbies. But he would only take the medicine from me. He did not own up to it. He didn't make that connection that the medicine was helping him.
Sheila, we probably have about another minute or so. I want to make sure, yeah, I know, it's great to hear your perspective on this. Is there anything, just as you wrap up, is there anything that you would want to request as a parent? What is your request of the mental health system?
We didn't even get to the
Yeah.
to the justice system, and that's okay.
Yeah.
There also, it's the same situation. But what I'd like to request is, I'd like to share a quote from Australia. Mental fitness is a team sport. And these are the points, like 4 or 5 points on treatment. Follow through long enough. In-person medication finessing. Because when he lost Kaiser, he was put on a different medication at Marin General through the county, Sonoma County Behavioral Health. And that just was hard to finesse when he started having problems with that. He started gambling heavily. And I got him SSI without a representative. And he gambled the lump sum treatment before I even knew the lump sum award. So he wasn't working now, he had this SSI, but the medication wouldn't have let him work anyway. And then respect that he's not broken. If we could have patient-centered therapy where it's not so much you are your diagnosis. That's why my son hates medicine, because it stigmatizes him just by taking that. So I'm all for medicine right now. 4 years of psychosis, I'm so afraid that his condition has progressed to the point where it'll take a little bit longer to bring him back. But I also, 2 more things.
Okay.
People looking out for people. Consistency with the therapy. Talk therapy, so important. And I won't quote the books that I, a consistent living program, the housing support. It can't be any other way for Nico. Consistent supported housing with people that are looking out for each other. And then the last thing, and it's something that Thomas Insel also suggests in his book, Healing, that as is found in another place in the world, all the people, the clients, are part of ongoing research projects. They are in active research on all different levels, different approaches. And I'm sure some of the tests that I was looking into. He also said there's a lot of hope for doing EEGs. Is it EEGs? Yeah, EEGs, monitoring electric activity. I know my son has an issue with his brain. Dr. Amen and his institute cost $4,000. I couldn't do that. And to image his brain, I tried. I looked into a private psychiatric facility. I called them, and she told me their whole program. You wouldn't believe. I don't know, I won't name it, but you can research it, and it's incredible. What they offer was work, but it cost $50,000 for the first 2 months, and then I think $15,000 each month after.
Well, yeah, I mean, it sounds like there were just so many attempts, as a parent to try to get him the help he needs. And it also sounds like something you said, which I thought was very important, is that it was hard to know the path to help or treatment for him. There were just, I remember you saying there were so many different therapists and clinicians and psychiatrists over the years that he saw. But I wanted to see if, Chair Madrigal-Weiss, if any commissioners had any comments before we bring up the rest of the panel.
Excellent.
Sheila, I just want to thank you for being here today.
I'm having hard time hearing.
I'm sorry. I wanted to thank you for being here today and sharing Nico's story, and just know that we're all really dedicated to improving the system for all our children. So thank you for spending time with us today. And any other, I think we just all want to thank
honor.
you. Appreciate you.
Are you taking comments?
Please, Commissioner Mitchell.
So good morning, Ms. Sheila.
Good morning.
Can you hear me well?
No, I can't.
Oh, wow, that's unfortunate, because I want you to hear this. Let me see.
I have a blocked ear.
Okay, can you hear me now?
Yes, that's better.
Okay,
Thank you.
good. So I totally can relate to your story. Your mom, probably, just like all of us who have these children who weren't born with a disability, but at some point became disabled with this disease of schizophrenia. So hearing your story, I just resonate with so much of it, your period of trying to find the why, and just quit worrying about it, because we're here now. And so I had to quit trying to figure out the why. Did I walk too much? Was I under too much stress? Was I, I can just remember all of those questions. I think what I'm hearing is, for us as commissioners, and it really struck me, so there are different phases of when individuals get sick. So like in my kid's case, he was 13, induced by whatever. Your son was 22. And so I think we have to look at different systems or remedies, because someone at 22, he's never been in trouble, this break came, and you're trying to figure out, what door do I go through to get him help? So he had help with Kaiser, and then you lost the insurance, so where do I go from here? In my case, my kid had Kaiser. I was encouraged constantly to drop Kaiser and get help through the county, which really was a good deal, but it took me years to believe that, but it actually is true. I think what we really have to look at is, how do we make this system some way consistent, so that when a family like you comes into it, what are the things that we can do that just give you the immediate relief, as well as the feeling of some security with your son? Because coming home after a hospitalization and being with you as an adult, which you clearly could not provide the support that he needed, because he still was not well.
No.
But he was sent home.
After 7 days.
After 7 days. Because you're not well after 7 days, because you go in and get treatment. So we have to look at, how do we come up with something that includes the housing for an adult who cannot be at home.
He can't anymore with me.
Who cannot. Where do we look for housing that's not jail? Because we can't keep failing to go to jail, which is housing, and then get help there. That's not treatment either. I don't have the answer. I just know that as a parent, you are looking for a system that can stabilize your son, because the disease is not curable. We manage it, or they manage it. We help them to manage it. So it's, what is this door? What are these systems that are consistent, that are the same across the board? for when someone gets ill as a child or as an adult, because the systems are different as a child and as an adult. How do we create this system so that a 13-year-old or 20-year-old can get consistent help for not only them and their family, and we're not in this fragmented system of care?
Fragmented.
It's fragmented. You're going crazy trying to find, how do I get them the help? Because we know what to do with other health diseases.
Yes.
We just can't get it together with the billions that are being spent to make this system make sense.
I have an idea,
We better.
but I didn't mean to interrupt. I'm getting excited.
Well, so with that, Commissioner Mitchell, thank you. We have a panel who is going to help address that response, help us shape that response. So thank you so much again. Sheila, thank you for being here. Tom, with that,
Great.
if you could.
Honor.
Yeah, thank you,
please,
Sheila. I
thank you.
appreciate it.
Thank you, Tom.
I would like to invite the panelists up now so we can continue our discussion. Come on up and join me up here. Thank you. I know, there's a lot to say, huh? I'll give you my mic. Great, thank you. Yeah, to continue on with, some of your questions and concerns, Commissioner Mitchell, I think this panel will provide a lot of insight into that. We'll begin with our panel presentation with Dr. Rosa Negron Munoz. Dr. Negron Munoz is a triple board certified adult, child, and adolescent and forensic psychiatrist. She's recognized as a distinguished fellow of both the American Psychiatric Association and the American Academy of Child and Adolescent Psychiatry. Dr. Negron Munoz, if you could, please tell us about some of what we've already heard. Tell us about some of the early indicators of mental illness and the opportunities that we have that we may be missing for early intervention for children and adolescents.
Thank you. Good morning, everyone. This is the
Yeah.
clicker? All right. So thank you for inviting me here. I am a passionate advocate of early intervention, and as a child psychiatrist, I have very strong beliefs. So I hope this will help you. We know it's a fragmented system, and I'm really happy that you have this commission to hopefully get things in place. So I think I have like 15 minutes.
Well, we probably should go 10 because
10?
we're over a little bit of time.
All
So if you
right,
can do it in
so-
that'd be great.
Bear with me, because I know this is a lot of information. So strengthening early intervention to reduce criminal justice involvement. Yantra Psychiatric Services is my company, and the reason I put this here, I'm not sure what I did.
Oh, we lost the slides there. Oh,
There we go. So the reason I wanted to share this with you is because I believe in a holistic approach of treating the person. And before I started my company, Yantra, everybody asked me, what is Yantra? And everybody knows what a mantra is, right? Mantra is something you repeat. So a Yantra is something you look at to focus. So as I was coming up with my company, I came up with this Yantra. This is our Yantra, and if you see, it has 4 openings, because my belief is that you can come in at any point in life and make a difference. So that's why we have, on the right-hand side, the scope of the youngest child to the adult. My business consultant told me some people may see it as too new age and may not come to the office, so I had to defer to another logo. But he promised me I would get one, so I have one in my office because I really believe in this. So we have the colors of the chakra because we need to balance the whole person. Not necessarily in chakras, you don't have to believe in that, but we have to balance the whole person. And the symbol in the middle is the symbol of inner strength. So we can come in at any point and help whichever person is dealing with mental health issues to develop their inner strength. So I wanted to share that with you. I'm not sure, where is this? All right, so these are points for me not to forget that they asked me. And the description of my involvement with the justice system. So as Mr. Orrick said, I'm a trained adult, child, and adolescent forensic psychiatrist. I did my forensic training in Rikers Island, Sing Sing, Bronx Psychiatric State Hospital, Bronx Children's Psychiatric Hospital. And within New York, we had mental health court, different correctional facilities, ACT teams, assisted outpatient treatment. So it was a very broad, diverse levels of involvement. I was one of the first child and adolescent forensic psychiatrists, so my program director was very helpful in ensuring that I obtained that child piece because everybody mostly was an adult forensic psychiatrist. I've worked as a designated mental health authority for the Florida Department of Juvenile Justice at a level 6 and 8 residential treatment facilities. I've been a psychiatrist and consultant for several companies that contract out services for the Department of Juvenile Justice in Florida and New Mexico. Those are some of the companies. I was the lead psychiatrist for Hillsborough County Jails in Tampa, consultant for the Pinellas County Jail in Florida, and a very special program that's dear to me. We started a couple years ago a program called School for Academic and Behavioral Excellence, which was to identify children with behavioral problems, and it was kind of like a partial hospital within the school district, and I can provide more information on that later on, to help identify children with behavioral problems that once they get identified, it's like you're bad. And we're not really looking at the reason why, quote unquote, they're bad. So I was part of that program. The children would come for 9 weeks at a time. We would do testing, we would evaluate, medications if needed. And what I really loved about that program is that it allowed me the time to sit and get the information, not a 15-minute in and out, get out. So what are the lessons learned about the types of early intervention services needed to help an individual avoid incarceration? And I put this here because are we like the three wise monkey? You know, we hear no evil, see no evil, speak no evil. Because as long as it doesn't affect us, we just move it along. And this one I found very interesting. I'm like, or are we the three wise monkeys? You know, and I found these very interesting because we kind of collude with each other, you know, in not hearing, not seeing. I like the monkeys in the upper left-hand corner because they're just eating junk food, they're watching videos, they have the music, things that we all talk about. And then these other ladies and the other ones, it's like a circle. So are we the three wise monkeys? You know, that really hear no evil, see no evil, speak no evil, because as long as it doesn't affect us. So what are my lessons learned about the types of early interventions? It's never too early. And prenatal care, early development, preschool, early school, anything after this will already be too late. So this is what I came up with. When do we really? If we have a mother, right, that has her own mental health issues, or we can identify in the prenatal care period that there is already some stressors, that's where we should be intervening to help for developmental problems. Let's assume that's not an issue. Then early development, when these children are being identified, they're not talking correctly, developmental milestones are not being reached on time, they have severe temper tantrums as a baby. And when I mean severe, not just a regular tantrum. And I know there's some kids will be kids, and everybody, I get this from my family, like, you're a psychiatrist, you want to, everything is medications. We were having this talk, but there's a difference. When I trained, we had a normative experience, so we know what's normal, and then we saw, you know, what could be a pathology. So early development, preschool, I am a huge fan of. We spend about $40,000 a year in adults that are incarcerated. If we do early intervention and we do testing to test them for psychological issues, their IQ, their learning disabilities, whatever it may be, and teach them how they need to learn, because this is not a one-fits-all model. So preschool, if we can get that IQs kind of standard, that will help us get them the interventions that they need, or elementary school, or middle school. And what I have here is you see the risk arrow. The later we intervene, the higher the risk. So the sooner we can intervene, the sooner we can help the family, the patient, the child, whomever, and they can have a better outcome. Usually after middle school, which is a lot of what we see in the Department of Juvenile Justice, they're 13, 14, and by that time, we've crystallized some thoughts and feelings about this is what my life is going to be, I'm not going to get out of here, and it's going to be harder to implement systems for them. So it can become a never-ending cycle. And everybody's going to be different. So the challenge is coming up with a system that works for everybody, but that at the same time can be flexible enough to take the intricacies of every family, every individual, and work with them differently. So here in this picture, we can have a person who only has one stressor, 2 stressors, 3 stressors, 4 stressors, 5 stressors. So let's identify them and see how we can help the family. Things that I have seen in treating these families in the schools, for us, we're lucky we can say, well, this is very easy. You know, we can do this. But when these families have financial stressors or other things, really getting their kid to an appointment may not be the first thing on their mind or be able to. Sometimes they don't even have the means or the transportation. We were talking yesterday about internet. Sometimes people don't even have access to the internet. Oh, it's real easy. You just go on your phone. They may not even have money to pay for their phone. So it depends on where you're at on the socioeconomic status and life. So how early intervention services for children, youth, and young children could shift the trajectory away from negative outcomes such as homelessness, hospitalization, and incarceration, and towards a life of health and wellness. So provide appropriate services at appropriate stages. And I think when we look at this individually, we say, oh yeah, we know, development, diagnoses, treatment, education, follow-up, and financial. Sounds pretty straightforward, right? But there are so many intricacies within each of them. Developmental, we want to make sure they're hitting their milestones. Diagnoses, it is known by research that it can take up to 5 years to obtain an appropriate diagnosis. So this is why sometimes if you're not familiar, you see a patient and they tell you, I'm bipolar, I'm depressed, I'm ADHD, I have PTSD, because depending on how they present to that particular practitioner at that moment, and it has to do with the care. There's not consistent care. Doctors are moving, you know, they're shifting. And mental health is important. You don't want to share your psychosis or your paranoia with everybody because are they judging you? I mean, it becomes an issue. So making sure we're treating right, that the diagnosis is right. Treatment, access to treatment. This is one of my biggest pet peeves. You stabilize a patient and then the insurance tells you, well, no, can you give them something else? Well, no, I can't because they're doing great. But try to argue with them, you know, or try to make this point. Education, and when I mean education, it's a two-prong here. So it's education of the families, education to the patient, that they understand their illness, and also their educational component, how they're moving along in, you know, life, first grade, second grade, moving along, and financial, which can be a big barrier, not only for co-pays, even if they have insurance, sometimes people don't have the money for co-pays or the co-pays for medications. So that is something very important as well. So what is the proposed model? I have a colleague whom I worked with in Bradenton, Florida, and I have her permission. And we have been using the therapeutic education model. And like I said, it seems very easy. So for elementary school, she calls it the three-legged stool model. You identify a patient that is at risk, and then you implement systems for the community and the family, for mental health, and for education, school. So in the elementary school level, if we address these things you can imagine, it's very much more in-depth than this. It's very simplified here. Then we can help the student be more successful. In the education component, we want to identify early identifications of learning barriers. Do they have a learning disability, a nonverbal learning disability? Are they dyslexic? Do they learn different? So one of the things that I learned, I was sharing with one of the commissioners, I think yesterday, is when we had the school SABLE, I would ask, at what class is this kid acting out? Is it a specific class? Is it a specific time? And teachers would get annoyed with me. They're like, Dr. Negron, we don't have time to monitor the time. But it is important because what we wound up seeing is that most of the time it was the same class. It was either reading or math. So they're having problems with that class. So why would we, get upset with them? Let's try to identify what the learning difficulty is so they don't act out. Instruction, the way they learn. Are they a visual learner? Are they a hands-on learner? The curriculum, it needs to be appropriate to each student. And Michael J. Fox says if students don't learn the way we teach them, then we need to teach them the way they learn. So that's a big one. Environment, at home, the environment that they're learning. Are they able to focus? Are they a one-on-one learner? Are they a group learner? And we know that in schools, it's very, you are good and make it or you don't. Learner, what type of a learner? And I think I mentioned that already. The mental component, psychiatrist, counseling, positive behavior program. I am a true advocate of having psychological testing. And another thing that we do at my office is we get pharmacogenetic testing if medications are needed to make sure we're kind of going on target with what medication, that we're not just throwing blanks. And we also have neurotransmitter testing, which tells us what are the biggest components, serotonin, norepinephrine, dopamine, that will help us kind of do a better target of treatment. And in the schools, I think just like recess, all kids should have a counselor. And yesterday, as I listened to the patients with their counsel, when I was done, I told my colleagues, I said, well, they said everything I was going to say. They basically have identified, they know what they need. They need early school intervention counselors. And I sat there, I was like, well, they've done my presentation for tomorrow. I'm done. But instead of other things, community and family component. The family involvement and community agency involvements, which, like I said, can be very, very broad. It's just very simplified here. And then we have the therapeutic educational model for secondary school. So what we do here is we're adding career planning. Not everybody in this world was born to be a doctor, a lawyer, with all respect, a commissioner, whatever it may be. We need plumbers, we need welders, we need people to pick up the trash. So not shaming people. Those are careers, and not making them not have the expectation that you need to have a college career in order to be successful. So educating them, maybe they're best doing X, Y, or Z. So helping them in that career planning so they don't get frustrated and drop out of school, and then they wind up in, jail, et cetera, and it becomes that cyclic pattern. So after we had one of the meetings, Tom asked me briefly if I had some numbers, and I put this in a couple years ago, because this has been a passion of mine for years. I did a study that was presented at the National Academy of Psychiatry and the Law about educational factors contributing to juvenile delinquency. So when I was in training, my very poor thought was these kids, they have to have a low IQ. They're getting in trouble because they don't cognitively get it. And my program director's like, oh, that's what you think? Go ahead, do the research. So obviously that was not the case. So then I moved on, what are the educational factors that contribute to juvenile delinquency? So there's a noticed trend that juveniles in facilities have educational difficulties and grade retention. Limited studies, we don't have a lot of information on this. Behavior in school is associated with desertion and eventual involvement with delinquency. I can't even read that. Improve education, to reduce involvement in juvenile delinquency. Thank you. Improve identification of educational difficulties, and provide appropriate educational settings. So what I did at the time, I was working at the Hillsborough County Jail. I was working at the juvenile facilities. Because no names were going to be identified, I was allowed to do a chart review. So we did 100 juvenile males, 100 adult males, and we did chart review: age, race, the last grade completed, level of education, grades repeated, if they had a history of special education, and this is a very small number. So what we found out is that the juveniles, their average age was 16 to 17 years old. The race, it kind of varied. In adolescence, they were more minorities, but then when we went to the adult jail, it was more Caucasian. The highest grade completed in average was the 9th grade. And what I found in this study is that there's 3 sentinel grades where children would have difficulties. It's the 3rd, 6th, and the 9th grade, because these are grades where we change the type of education and how it's treated. So up to 3rd grade, there's a lot of support. You have the teachers, giving them their notebooks and their agenda. In the 6th grade, you're expected to have a little bit more independence and follow your own things till you get to high school, where you're expected to follow your own agenda. And then you get to college. So these 3 grades were found to be very important. So it's important to identify when a child has repeated the 3rd grade. That should be what's going on here. Let's identify here. And the 9th grade, then what happens is they're already old enough, and then they drop out of school. So I don't even know what this one is. Oh, the grades repeated. So what we saw as well is, as you can see, that the grades repeated were consistent. It was either the 3rd, 6th, and 9th grade. We found a consistency in that. So out of all the juveniles that we saw, 69% had repeated a grade. So out of the 100 children, juveniles, 69 of them had repeated at least 1 grade. And 22 of them had been identified to receive special education. 11 of them were receiving special education for behavior, 6 for learning, 5 for reading difficulties, and 3 for math. And 18 of the adults had identified receiving special education. But if I can make a side note, probably all of them, if you asked them, in hindsight, would say, well, if I had the education that I needed, or the teachers, there's a lot of frustration with teachers. I know they're overwhelmed as well. But all acknowledge, if I would have been taught a different way, this would have had a different outcome. So the road ahead, I leave that up to my colleagues here. It's a very long road ahead. Thank you for having me. There's some references there. And there's so much more to talk about this, so thank you.
Thank you, Dr. Negron Munoz. I appreciate it. We'll move on to our next panelist. Our next panel presenter is Dr. Melanie Scott. Dr. Scott is Assistant Deputy Director for the Community Forensic Partnership Division at the California Department of State Hospitals, overseeing the Forensic Conditional Release Program, the Jail-Based Competency Treatment Programs, and the Early Access and Stabilization Services Program. Dr. Scott, tell us about the opportunities that you see as you've talked to so many people in your career, the opportunities you see for earlier intervention for those who commit a misdemeanor, and your thoughts about the use of jails as mental health treatment facilities. Thank you.
All right, thank you. Good morning. I really appreciate the commission inviting me here today to talk on this panel. I'm really excited to just share information that I have, and I'll do the best I can to answer some of these questions here, Tom. So I was just providing a perspective on individuals with serious mental illness and criminal justice involvement. As Tom had said, my name is Dr. Melanie Scott, and I work with the Department of State Hospitals. So I was going to give a little bit of information about my background, and I just felt like this would be helpful just to frame where my perspective is coming from. Well, really in my background, I am a forensically trained psychologist. I'm from the East Coast. I've been in California now for about 10 years or so. I got my doctorate degree over in Connecticut. That's where I'm from the University of Hartford. And then I had done a postdoctoral fellowship at Yale University in the Division of Law and Psychiatry, and that's when I became specialized in forensic psychology, and that's when I really grew a love for the patient population and the work that we do in forensics. I can say what I find interesting about my career is that my career has moved along the continuum of care. So I originally got into psychology because I had wanted to be a child psychologist, and I was sure that was going to be my calling. So I started working with children, loved the work, but then I had always noticed that it didn't seem to be the children that I wanted to work with, but the parents. So then I said, I'm going to go in and work with adults. That's what I'm going to do. Started working with the parents, was working with the adults, and then I noticed the parents that had more difficulties with substance abuse seemed to be the parents that had more of the challenges. So I really wanted to work in substance abuse. So I did that for about 10 years, and then from there naturally progressed into a career where now I work with in forensics. So I also want to just share, too, that I worked in a lot of different treatment settings, and I think that also frames the perspective that you'll hear from me today. So I've worked in outpatient settings, I've worked inpatient, I've worked in residential settings, I've worked in assertive community treatment programs, drug diversion programs, and before I worked with the Department of State Hospitals, I had worked in the jails. I had worked in West Valley Detention Center, which is in San Bernardino, for a couple of years. And during that time period, I can say that I developed a respect, too, for the jails and for law enforcement and the challenges that they experience and face when they have a population of individuals that are in the jails that have a serious mental illness, and the challenges that that brings while they're incarcerated in those settings, as well as the reentry issues that occur. Okay, well, what we know in the literature is that about 16% of jail and prison inmates have a serious mental illness. And I feel like that's a common statistic that's been said before, and it's really a high statistic. So that includes individuals that have been in federal and state prisons, as well as city and county jails. I have a couple more statistics I put here, too. So the second one I have is that people with mental illness in the U.S. are 10 times more likely to be incarcerated than they are to be hospitalized. And I think that's a very important statistic to share today and make sure that individuals are aware of that. And the other statistic I have here is that in the year prior to arrest, a major mental illness diagnosis was associated with a 50% increase in the odds of a jail sentence for misdemeanor arrestees. So I think these statistics really just show that there is an overrepresentation of individuals that have a serious mental illness in the criminal justice system. Jails are correctional facilities, as we know, and for that, their primary goal is not long-term treatment for individuals that have a serious mental illness. But as we know at this point in time, jails have become the de facto mental health facilities right now for individuals that have a serious mental illness. And I feel that that has occurred because jails have been impacted by upstream systemic failures. And this is my opinion about this. Okay, so on my next slide here, I have a couple of broad points that I was going to just be making about some things that I think about in my career right now at this point in time. I have a couple of other slides where I talk about things I've thought about in time over the course of my career as well, too. But I'm going to start with this first one here, and it's just related to, again, where I'm saying there's upstream failures that are occurring. And the first thing I have here is that there is insufficient immediate availability of community mental health and substance abuse treatment for individuals that have a serious mental illness. I know that sounds odd to say because we fund so much for mental health treatment and for substance abuse treatments, but yet there still remains to be an insufficient and very few immediately available treatment programs. And what I would say is that what I tend to see from my perspective is that many of our systems have wait lists for individuals to get admitted into treatment programs, and there's lengthy wait lists for admissions. And also, tends to be a wait list just for individuals to get the evaluation to determine if they're even eligible for the treatment services that they're seeking. I find that to be a very significant issue, and if we're talking about a forensic population, that means you also have to build in the time frame it takes for the court to calendar their hearing and schedule their hearings as well. I know there's been a lot of presentations as well more recently about deinstitutionalization and that impact and what that has meant. And that's really just speaking to the fact that in previous decades, there had been more of an infrastructure in place for individuals that in the community who have a serious mental illness. There had been more robust services for individuals with severe mental illness at that point. But now, over the last decades, there's really been a shift to an inpatient structure, and individuals get referred into the inpatient system instead. So now what we tend to see is that there has been a diminished number of programs that are immediately available in the community for individuals that have a serious mental illness. I have here on point 2 as well that I would argue that, the training for individuals who are mental health professionals in the community around treating populations of individuals with serious mental illnesses also has diminished in time. It's really important that individuals get training for this because oftentimes what you might hear is that we need our inpatient system, which we do, but that everyone needs to go into the inpatient system. And what I would say as a clinician is that not everyone needs an inpatient level of care. There's a level of care that's built into these systems for a reason, and it's up to the clinicians and the mental health professionals to do those evaluations and to determine what that appropriate level of care is for an individual. So if people are trained, mental health professionals are trained well, they know effective treatments, what's efficacious to provide in terms of treatment, individuals can be safely treated in the community, close to their families, being able to re-engage in the community, having vocational services, and getting back to their lives if we do have the infrastructure in place and we have the training available for mental health professionals. I would also say, too, that in terms of effective treatment, I'm a big proponent of data. I feel that data is really important to know how our treatment programs are operating, but also to make any of the changes and tweaks that we need to make sure that the programs continue to do exactly what we're hoping that they would be doing. Point 3 here I have is just an overall point, just saying that there is a shortage of mental health professionals. There's for sure a shortage of psychiatrists and nursing staff across the state. So I think that impacts our community system, our jails, our residential systems. Everyone is affected by that right now. So I just want to make a point about it. Number 4 here I have is just a point from my last slide, and that's the fact that people with a mental illness are 10 times more likely to be incarcerated than hospitalized. I think it's really great that we're going towards where we're trying to build out our community infrastructure for individuals with a serious mental illness right now. But currently what tends to happen is because we don't have that system fully functional and fully built out in the way that we need to, is individuals instead they get in contact with law enforcement. And then after they're in contact with law enforcement, they really get connected into that system versus them getting connected into our community mental health system. So oftentimes what we'll see is that individuals might even have low-level crimes, but again, they're being connected with law enforcement, and then in time they build a rap sheet. And if you build a rap sheet, you're more likely to be rearrested in the future because you'll have prior charges as well. So I have here for point number 5, it's really around ensuring that we have a better warm handoff for individuals when they go from one system to the next. What I'll say here is that when individuals leave one facility and they're going to the next, what I've seen in my experience has been either people have bad insurance or they have, maybe they have Medi-Cal or something like that as well. But let's say, for instance, an individual has bad insurance, they go into to get treatment at emergency room or some type of crisis care, they leave with a hefty bill that they might be required to pay that they cannot afford to pay. I mean, leaving the emergency room with a $6,000 payment that's due just really is not fair within our system. I would also say that for individuals that are not getting that warm handoff, again, the problem that happens is, like I was saying a bit earlier, instead of them getting connected into the community mental health system where they can get onto Medi-Cal, where they can get their benefits started, start their medical treatment, and get to be known by their community mental health providers, they're instead known by law enforcement. I have a slide in one of my next slides that kind of speaks to this a little bit more, but I think I just want to really emphasize that our system needs to do a good job of when individuals leave one system and go to the next, maybe we make a phone call. Maybe we find out if there's a way we can send a letter to someone, making sure we get contact information. I know that's challenging because sometimes individuals might not have a phone or might not have a stable living environment, but again, just really emphasizing that that handoff is an important part of the treatment as well. Really quickly here, I was just going to speak to incompetent to stand trial, and I think this is relevant because individuals who are found to be incompetent to stand trial are individuals that have a serious mental illness, but also have been involved with law enforcement, so they have criminal charges that are pending. So really quickly, just sharing, I work with the Department of State Hospitals, and over time, what we've had to do is build out a continuum of care. We do a lot of treatment for individuals that have a serious mental illness, and this is the continuum that we've really built out over a number of years. Literally within the last 7 years, we've been building many different levels of care and within our infrastructure. And honestly, I'd say within the last 4 years is when most of the building of new programs has occurred. But if you can see from this diagram, what the Department of State Hospitals originally had was more in the blue, which was our jail-based competency treatment programs, which is our most restrictive setting and inpatient, followed by state hospitals, and then the outpatient through the conditional release programs, which are CONREP. In orange are all of the programs that literally have been built out within the last 4 years, I would say. So what the Department of State Hospitals had to do to build our infrastructure that might be helpful for the community to know is really building in pre-admission programs. So those are programs where an individual can be treated or evaluated while they're still on a wait list for admission into a DSH facility. So what we found with this is that people might be evaluated and it's determined that they no longer need our treatment services, so we can continue to steer them back into out of our inpatient system or the inpatient pathway. And then we've also found that people that start treatment earlier become psychiatrically stabilized, and that makes improvements so that either they no longer need to go to an inpatient level of care, or when they do go into an inpatient level of care, they're so much more psychiatrically stabilized, it reduces their length of stay. Again, quickly through this slide, on the left side is the definition of incompetent to stand trial. And again, I feel like this is very relevant because these are patients that have a serious mental illness and have just been involved with law enforcement, if you think about it in that way. So these are individuals that have a serious mental illness, and at the time they went to their proceedings, they didn't understand their criminal proceedings, they weren't able to assist their attorney in the conduct of a defense, and for that, the court would commit them as incompetent to stand trial. trial to like Department of State hospitals. But what I think is more interesting that the group might be very interested in seeing is on the right side. That's the characteristics of individuals that were incompetent to stand trial and admitted to one of the 5 state hospitals across the state. The citing for this reference is there at the bottom. But really the characteristics are that they were male, they were commonly diagnosed with a psychotic disorder or evident symptoms of psychosis. They evidenced cognitive disabilities. The charges had tended to be for assaults and battery, thefts, or robbery, but also there were lower level charges as well too. What's very important to share is that more than 50% of the population were unsheltered homeless. Unsheltered homeless does not mean just living with family or friends or not having a place in that way. Those are individuals that are living on the street. They had no couch surfing, no friend's house they were living at. They literally had no place to go. Another important statistic here is that I believe it was about a third of the sample size had 15 or more prior arrests. I think that's one of the most important statistics here to share, or characteristics, because that means an individual had been arrested more than 15 times and still ended up in our inpatient system, and connected with the next 2 statistics here, that they had not been consistently connected with the community mental health system or having benefits from Medi-Cal. So in the 6 months prior to these individuals being admitted into the state hospital, they had no record of billable services through Medi-Cal, which means they had not at all been connected with the community mental health system, and they had been arrested 15 times, and nothing in our system had addressed those unmet needs, unmet needs, or those issues that they were experiencing. So I think those are really important statistics to share. This is my last slide, talking about some observations from evaluations. Again, I'm a forensic psychologist, and thinking about throughout my career things that I've seen that might be helpful in just answering some of the trends of our patient population and what I've seen. So the first thing sounds, again, like many of the things we've heard today already, that there were early signs of mental illness that were never addressed. So for instance, unstable living arrangements and homelessness, substance abuse, or an absent parent. And I'll say where this information gets picked up is, as a psychologist, when someone's admitted into a facility, we do what's called a biopsychosocial evaluation. So during that evaluation, you ask lots of questions about history to get a baseline of that individual. And some of those questions are as simple as just asking, when's the first time you used substances? And one thing I remember that was pretty remarkable when I was, before being a psychologist and just training and learning how to do biopsychosocial evaluations, is of doing my first, and someone said they started using substances at age 8, and I just remember thinking like, oh my gosh, that's not possible. Age 8, this individual started using substances that early, and at that point in time in my career, that was novel. That was very surprising to me. Many years later, I feel like that was pretty common. When I had worked in substance abuse for many years, many individuals indicated that they had started using substances at very, very early ages. But again, I had worked with adults when I had worked in substance abuse. So again, many years that people had been using substances. The other thing I have here is that they were unable to obtain immediate help before a crisis. I'll speak to that really quickly too. I can think about patients that I've worked with where, this was speaking to an earlier slide that I had said about just the immediate availability of services. I feel like there's a time period before an individual goes into crisis where they're searching for services, they're searching for help. And the problem is they're searching for help, and I've seen where individuals have reached out, almost need a notepad and a pen to write down the number of different places they're told to call to get help for the services that they need. Then when they do call for those services, they're put on wait lists. like wait lists for a week or 2 weeks just to get their evaluation done, and I find that to be unacceptable at times. The other thing I have also listed here is that there's a disjointed system between our mental health and our substance abuse system. If you have a co-occurring substance abuse issue as well as a mental health issue, oftentimes you're given 2 different phone numbers to call and 2 different wait lists to join to again be evaluated to see if you can get the services that you need. The next things I've spoke about, I have the prevalence of trauma is high. I want to make sure it's clear too that when we think about trauma, we think about individuals that have had a traumatic experience that directly happened to them. But when we think about individuals that have had or experienced auditory hallucinations, visual hallucinations, as well as paranoia, they are very fearful for their lives. They're very fearful for things that could happen to them, and just remembering that that's also inclusive of them experiencing and feeling that they have been traumatized. Trying to go through the last of this quickly. I've spoken earlier about the fact that they're not connected with the community mental health system and often with law enforcement. I think this next point about being unable to connect with the family due to privacy, of course we know there's an important purpose for a release of information, but oftentimes we'll get phone calls from family members that are really trying to get in contact or get information or be involved in an individual's treatment, and there's really a lot of power in being able to have those family members connected and have the opportunity to have conversations with them, and however that can be done. High reliance on crisis intervention, as I was saying a little bit earlier. I mean, people need to be connected with the community mental health system before they are in absolute crisis. And during that period of time when they're given a bunch of phone numbers to call and to get on wait lists, people need treatment then. They really need to get into the treatment before they start decompensating much further. Unsustained prior connections with the community mental health system. I think that was evidenced in some of the statistics I had shown before earlier. Stronger warm handoff, I had said that earlier, and just hopping back up to the system navigator. Again, having a notebook of writing down multiple phone numbers that an individual needs to call, it would be really great if our system was able to designate a navigator or someone to help people navigate this system. Honestly, I work in our field, and if I had to navigate this system when I haven't been involved in knowing what resources are available in my particular county, it would be highly difficult. So expecting our patients and our family members and just individuals, families to have to navigate that is a bit unfair. So if there's ever funding available for something like that, I think that would be a great addition too. I appreciate being here today, and I thank you for the opportunity. Thank you.
Thank you, Dr. Scott. That's sobering information. Appreciate it. Our next presenter is Dr. Kara Klein, MD. Dr. Klein is triple board certified in psychiatry and neurology, forensic psychiatry, and addiction medicine, and is currently serving as the Associate Medical Director and Lead Psychiatrist for Advancement and Innovation for the Department of State Hospitals. Dr. Klein obtained her medical degree in Chile in 2002, and then completed her psychiatry residency in Brooklyn, New York, and her forensic fellowship training at Georgetown University. Dr. Klein, we heard about some of the revolving door in and out of the system, even at the state hospital. Good to hear about the continuum being built, but tell us a little bit more about early signs and symptoms and what we can do to address the needs of people with severe mental illness.
Sure, thank you. So I'm Kara Klein. I also hail from the East Coast. I did my training in Brooklyn, so very inner city settings, both in city, county, and state hospitals there. And then moved over to DC, where I similarly worked in state hospitals and then in correctional facilities and state facilities in the DC metro area. Share some of the background with my colleagues. I also did quite a bit of research in Connecticut at Yale, and then California stole me 7 years ago. over the years, I also thought that I was going to go into psychiatry, wanting to be a child psychiatrist. Very quickly realized that that was not, in fact, my calling. But in fact, was immediately drawn to the severely mentally ill, and particularly the institutionalized severely mentally ill. And please note that I say institutionalized because that no longer means hospitalized. So I didn't bring any slides because I, number one, correctly suspected that my colleagues would say most of the things that I have to share with you, maybe like even more smartly than I possibly could, but I'm also trying to just maybe throw a few thoughts out there so that we can actually have a meaningful discussion and capitalize from that inquiry instead of me just throwing data. Where I'm at right now, I currently, yes, I oversee the clinical operations of the 5 state hospitals in California, and I collaborate with our Community Partnerships Division, our Forensic Services Division, to build out and to support our correctional programs as well as our community programs. I also have a private consulting practice where I do forensic consulting in criminal and civil matters, and I do some clinical consulting on the most severely mentally ill patients who are not, in fact, institutionalized. I think that private practice perspective is relevant. I've also worked in community inpatient facilities, psychiatric emergency services, and the realities that have been shared here before me are so evident and so devastating, not just for the patient, but for everybody in their network. And I've seen it firsthand. When I'm asked to do a forensic consult on a criminal matter, I, again, specialize on the very severely mentally ill and oftentimes the worst of outcomes that have resulted in death. So that's sort of like my area. I focus on cases that have resulted in death or where death is at stake, such as death penalty matters. And I also focus on severe malpractice cases. And so what I see is the worst possible outcome, right, on a daily basis. And weird as that might sound, that's what I enjoy the most. So, so I do think that the issue of the community phase of care cannot be understated. And similarly, when I do clinical consults in my private practice, the people that I end up serving are people of means that really the vast majority of our population does not have. But those are the people that can really afford to have a consult that takes 3 or 4 hours, that takes extensive testing, such as I also do neurotransmitter and psychopharmacological genetic testing, that does neuropsychological testing. And those are just costs that are not covered by any carrier and that the vast majority of people just cannot afford. So I'm very conscious of both. I see these people on every side of that coin. It's not a coin, I guess I don't remember geometry enough to like tell you the shape that's in my head, but I think that you know what I mean. So then what happens is that I see the public sector aftermath of it all in the Department of State Hospitals work. And I should emphasize that my opinions shared here are mine and not, and there's sort of an amalgam of my experience throughout my career and also in all of these different settings that I'm sharing, so not necessarily the position of the Department of State Hospitals per se. But what ends up happening is that I do see the decades of that, whatever that might be, when they end up with us. And that's when I see the pentagram of combination of our patients. I think Dr. Scott shared a little bit of the characteristics or profile of our IST population. But really what we see in all of our legal classifications is a combination of 5 things. A very severe mental illness that has often had early onset of symptoms and has gone for a long duration of untreated. And it's usually comorbid with medical comorbidities, particularly the hypertension, diabetes, chronic medical conditions that are treatable in this day and age, cognitive comorbidities, cognitive disabilities, addiction disorders, personality disorders, and of course, what I call social adversity that includes homelessness, justice involvement, and severe trauma. So with that 5-angle combination, you have a very severe person, and you can't choose to treat one thing at a time. You're kind of faced with treating everything and having the hope of undoing years and years and years, not just of untreated that has stayed the same, because we also have to remember that untreated means worse, right? So every day that passes without treatment it's compounding interest. It just monumentally changes the clinical picture and landscape. So how did we end up here? And sort of to answer in a very roundabout way Tom's question, we want to go back. And how further back we go, I mean, we were talking with Dr. Negron yesterday about, Jesus, do we go back to, decades and decades and maybe centuries ago where we committed terrible atrocities against the mentally ill? Maybe we do need to hold ourselves accountable for that and do some repair, because a lot of the stigma that we face is not just Hollywood's fault for portraying us in only horror movies, but some of it, we did, and then we acknowledge that we've moved on, that our treatments are better, they're kinder, they're safer, they're more effective, but we just assumed that everybody else had learned it alongside with us, and we didn't pause to do the reparative work with our community so that we could earn their trust back. We do it, or I want to believe that we do it on a one-to-one with each one of our patients and their families, but I don't know that we've done it as a field towards our community, or at least not enough. So if we go maybe perhaps not that far back into a historical tragic time, but we do go back a few decades to things that we did or that were done by the community with the best intentions in mind, and that a little bit have backfired, right? Maybe backfired is a strong word, but there's an element to that. Case in point, Dr. Scott mentioned the issue of privacy laws. Of course, we use privacy laws to protect people, to protect their autonomy, to protect their sort of the integrity, their choice, their freedom. But it backfired because we also know that family interventions, especially in psychosis and particularly in the first episode of psychosis, is critical to ensure and to reduce rehospitalization at 2 years by almost 50%. And so when you think about asking a person in the throes of psychosis who is afraid of everything and everyone to have this decision about privacy and perhaps are afraid of that family, doesn't allow us to initiate that repair work in that relationship as early as possible. So we do work around it, we work with it, but perhaps the language that we used, didn't take into account this other aspect or this other effect that it could have had. Similarly, when we instituted the issues of the right, not the right, sorry, let me take that back, but when we tied accessibility to treatment to dangerousness, right, that also backfired. What does that mean? Hey, my son is sick. No, he hasn't hurt anybody. Oh, so then I can't hospitalize him. Because commitment, and by commitment I mean hospitalization, by the way, just sort of my use of the term, commitment or psychopharmacological treatment is inherently tied to the presence of imminent dangerousness. And that did two things. One is that it promoted the stigmatization of the severely mentally ill, because you there was this association that the people that needed treatment were dangerous people. Therefore, mentally ill people are dangerous people. They're not. They're not. There is a slightly increased chance of aggression during an untreated episode of psychosis that reverts back to being very comparable to that of the general population. The exception to that being substance use, in which dangerousness does increase by 30 times over. And it's estimated that with a methamphetamine, it actually increases more than that. But regardless, the fact is that we established, that we cemented that, and by we, I don't know who we is because I wasn't involved in that lawmaking, but again, we're all in this together, so might as well call us we. But we cemented that association in an already mistrustful and sort of resistant community. The other thing that happened is that it tied the hands of the caregivers, right? I would much rather hospitalize an individual who is psychotic very early on in that psychosis and perhaps have a very short length of stay than have to wait until that psychosis has progressed to where he has had, or she, or they have had multiple ER visits, each of them for 8 to 12 hours, waiting in a really adverse environment, then being brought back into the street, then maybe getting arrested, then maybe getting released, then back to the ER. Let's repeat that a few times over. Now they're really dangerous, because even I would be. And now I can't. And now I'm like suddenly grateful that I can hospitalize somebody. The family's grateful. That's just not, I did him a disfavor, right? Because in an effort to protect their freedom, I actually deprived them of more freedom because the hospitalization ends up being longer, the incarceration ends up being longer, and the invasiveness of the treatment that is warranted sometimes is also higher. So the association of accessibility to treatment with a dangerousness component, again, I think the intention was good, I hope, but I think it backfired. And so again, I don't want to repeat some of the other things that have contributed to folks ending up presenting the way that they do at the state hospital by the time I see them. But some of the things have been mentioned already before. Dr. Scott mentioned the nationwide crisis of an increased number of referrals of patients, again, because of lack of services. There's a dramatic shortage of physicians in general in the United States, and if you want to get into like all the reasons for that, that's a whole different topic. Very passionate about that, and I can talk for a whole hour. For that one, I would have slides. But anyhow, we have a physician shortage, and we have in particular a psychiatrist shortage. That psychiatrist shortage has been very much felt in in California, excuse me. It is heightened or just made even more acute by the pandemic, where we see a fleeing of the workforce. And the fleeing of the workforce happens at different points or in different ways. What we see is, one, not enough doctors are getting trained. There's not enough spots in medical schools. There's not enough spots in residencies. The residents are often not completing or completing and then not practicing medicine, choosing other careers instead. The other thing that happens is a lot of doctors are choosing only administrative or only telepsychiatry positions. And again, I work with a hospitalized, so being present is something I'll get to in a second, but it's an intangible that's everything. So we have that. We have a fleeing of the workforce into private practice because when you have to deal with insurance companies and things like that, and just to be able to, you compound that, again, I could talk about the physician shortage at length, but The earning potential in private practice is obviously very different than in the public sector. And last but certainly not least, the rates of physician burnout and physician suicide that we're seeing recently are unprecedented. We do see a very increased number of suicide among psychiatry residents specifically. And I think that it also speaks to some of the challenges of the work itself. Now, a lot of people thought, well, couldn't we sort of complement the psychiatrist workforce with, for example, NPs, and I'm using NPs, or nurse practitioner. And probably not. What we've seen is that the NPs were designated, or were, the idea was to generate a lot of NPs so that they could cover rural communities, and the vast majority, between 50 and 75% of NPs actually do stay in urban settings, and so therefore the most underserved areas continue to be most underserved. There's an element that has been, I think, a resource that has been underutilized, which is the use of certified peer specialists. And by certified peer specialists, I want to emphasize that they do have to have the certified component of it with appropriate training and the capacitation to work with our folks. The lived experience is very important, but it's insufficient to actually carry out the duties of a peer specialist. And we do see a role for them in many different ways. To name a few, we have peer specialists that are sort of specialized in severe mental illness and vocational training for community reintegration, and we've seen them make an enormous difference. We've also used peer specialists in substance use disorder counseling and assessment, peer specialists that specialize in trauma-informed care. The possibilities are endless. And again, you know, going back to like the historical aspect of this whole thing and the question of the reinstitutionalization happened when, you know, there was a moment in which our folks were all out in the streets without treatment. The asylums were created, and the asylums were great. They had these communities, they were supportive, they had vocational training, they had a life inside the asylum. The asylums became exceptional when they became the de facto institutions of education for caregivers. Initially, the asylums trained only psychiatric nurses, and then they became the most coveted place to train for psychiatrists. And with that, the asylums were just a model of care. So much so that they became crowded because everybody wanted their kid there, or their neighbor there, or anybody who needed treatment there. But by that point, they were not popular enough to get the money that they would have needed to sustain that amount or that volume of care. On came penicillin, the medications. They were the deinstitutionalization movement of the 70s. And now what we see is the reinstitutionalization movement of the 2000s with incarceration instead of hospitalization. So I'll end on one last point, which is, again, it's my passion. Like, I work in essentially the ICU of psychiatry. It's, you know, at the end of the line where everybody thinks this person is too sick to ever get better, or in fact, this person is too much at high risk of death. And I value and I advocate very strongly for early interventions or community interventions. But I do want to highlight that there's 1% of the population. That 1% has been stable for the last 3 centuries since we've been studying it, that will suffer from a severe mental illness. And for many of those people, they need to have a hospital level of care. There is something that you cannot aim to treat at home when what you need is a hospital level of care. I mean, you wouldn't put a person with hypertension in the ICU, but you would put a person who had a massive coronary heart attack because of untreated hypertension in the ICU. It's the same thing. By the time a person needs to be in the ICU, they need to be in the ICU. And this is where we face the shortage of community beds, which in California is actually more pronounced than pretty much in any other state. Or in the state hospital if that's where they belong. But here is where there has to be a promotion of specialty care that cannot be equated with, that's similar. No, it's not. It's not the same. So there's a difference between a clinical psychiatrist, a correctional psychiatrist, and a forensic psychiatrist. There's a difference between an addiction psychiatrist and addiction counselor. There's a difference between treating with medications for addiction treatment and treating only with group therapy. There's a difference between treating with a number of psychopharmacological interventions and treating with interventional psychiatry methods. And so the science is so advanced, it's so advanced. And we don't expect everybody in the community to keep up, but we do expect them to refer timely, them to be able to identify when this is an ICU level that's needed, when they need to consult a specialist or a subspecialist, and when they have to fight for the services that their patient needs that they just don't have available. Something that we see a lot in the community is like, oh, we don't have ECT here, so can't do it. Or you need to find it. You need to find it. We definitely need to make it more available, but we also need to foster, I'm going to plug this in, Dr. Negron. I know we had a long conversation about what does education mean. And education means academic training, but it also means vocational training, and I also think that it means ethics training. We do need to encourage a system of values in our community that fosters that everybody treats SMI patients or any patient with compassion, with respect, but also with devotion, with a commitment and a personal responsibility to see that person through, regardless of the efforts that it takes. And I think that's a little bit lost. Again, we go back to like, what did laws do to us? There's a lot of emphasis on defensive practice of medicine. And a lot of people are like, no, because if I do that, it's on me. Yes, my man, it's on you, right? Like, let's make that honorable again. It's on you. But there's this adversity between the us and the them. And if we can bridge that gap, perhaps we will have a more glued together system. Okay, I need to shut up. We'll talk some more later.
Thank you.
And I think it's Dr.
Thank you, Dr. Klein. Appreciate it. Our final presenter is Dr. Jonathan Sharon. Dr. Sharon is the Chief Medical Officer for the Healthy Brains Global Initiative and was formerly the Director of the Los Angeles County Department of Mental Health. Dr. Sharon is a longtime well-being advocate who's worked tirelessly through his career on behalf of vulnerable populations in the public and private sectors. In his former role as Director of LA County Department of Mental Health, he oversaw the largest public mental health system in the United States with an annual budget of $3 billion. So Dr. Sharon, I'm sure you have a lot to share with us after hearing the panel presenters. Tell us how local mental health funding, specifically full-service partnerships, can be strengthened or leveraged in California to keep people with mental health conditions out of jails, out of prisons, and in their thriving in their communities.
Well, thanks very much, and it's great to be back at the OAC. I believe over my 6-year tenure in the county, I had 10 innovation programs approved because we had a lot of money to spend, and there still is money to spend, which actually is relevant for this conversation. And I'd like to recognize my colleagues in all of the comments, which I resonate with. And I am going to focus a bit on full-service partnerships because I consider them to be the meat and potatoes of community mental health. I think they're seen as a certain level of care only for those who have gotten to a certain point in their life. And I would say that I think that that's a mistake. To quote Richard Van Horn, everybody with a severe persistent mental illness ought to have a full-service partnership. He said that, I believe, in front of this group many, many times. First thing I'd like to talk about really is the client perspective. I mean, the clients have very difficult times getting access to care for lots and lots of reasons, including lack of insight about their condition, reaching out and getting burned, traumatized by the system rather than getting welcomed and embraced as someone in need. Getting a call from my daughter. Families and the maze that you have to traverse to get care, which is infuriating. And I would say that when it comes to a client, I have another IST moniker, which is inadequate systems of treatment. So the inadequate systems of treatment are not just because there's not enough capacity, but also their accessibility and the difficulties getting to them. And I believe it's Sheila who talked about next steps. I want to get to those next steps. But the other thing, and I'll tell you this as someone that came into the Department of Mental Health, I spent most of my career in the VA. And when I showed up within the first month, I probably got called by about 10 different emergency room docs who said, "Hey, we're so glad you're here. There's a new sheriff in town." And we have a client here with a psychotic disorder who's been brought to us by law enforcement, and they have a full service partnership, and we're reaching out and calling the full service partnership, and the response that we're getting is, "Oh boy, if they're there, they must be sick. So why don't you stabilize them? Let us know when they're stable and we'll come get them." In my opinion, antithetical to the full service partnership. I did bring a couple of slides that I dredged up from my days in LA County that I think are relevant to me, trying to describe what I call the domains, or really the program, in a simple way for mental health systems. Well, there's two, and those of you here, I think, have a printout. But the bottom line is that really there are three different domains that I'd like to recognize. I'm a lumper, not a splitter. And in the community, I would say that there are prevention efforts that are various, and one of the things that we did, which I think is relevant for early identification, is we leveraged what we call the community access platforms, the schools, the parks, the libraries, to identify people who were in need. And we developed a workforce, largely with peers, which we call the Community Ambassador Network. So we would have people in those domains identifying people with challenges, regardless of whether they were related to mental health, addictions, homelessness, et cetera, and then triage them to care. Social determinants of health. That's what the term we like to use. You know, the housing, the social networks, the training, the education, the jobs. Those are all critical parts of community. And then, of course, clinical care. So those three basic elements make up community. That's where we want to take care of people who are sick. It's where people need to be in order to thrive. The second is the crisis system, which really is made up of our intensive treatment, our emergency departments, our CSUs, our urgent cares, our inpatient units, our CRTPs, and we're constantly trying to build up capacity. Why? Because we know that people are falling out of the community. And when they fall out of the community for any type of an acute matter, we need to have a solid set of guardrails around that community for treatment to get people care and bring them back into the community meaningfully so that they stay. Unfortunately, the communities are not built up adequately in any of those three domains I mentioned. The crisis system is unfortunately Swiss cheese, so we have people spilling into what I call the institutions, the asylum of our time, the outdoor asylum of the street, the indoor asylum of the jail. And I understand that there are people who are really, really sick and are going to require ongoing chronic treatment for chronic illness, but I would include long-term institutions for the majority of the population. And there are parts of the world that embrace models like this, have built out community very intentionally and aggressively, and they don't have hospital beds that are overflowing. Their streets don't have people who have nowhere to go and that are actually languishing and generating more business for us when we already got too much. And then, of course, the carceral settings. So getting to next steps and getting back to the full-service partnership, the meat and potatoes. I am a psychiatrist. I'm a neurobiologist. And it's funny for me to find myself here talking about the fact that the biggest problem, in my opinion, is actually not the program. The biggest problem is the administration, the bureaucracy, and frankly, the payment. The way that the government delivers or supports the delivery of services. And one of them, full service partnership. And in many counties, and I would say in the county of Los Angeles, is probably the biggest line item in terms of a program. And as the meat and potatoes, we got to figure out how to make it happen properly. And the way to do that is not to continue focusing on process, fee for service, frankly, taking care of auditors, avoiding bad audit outcomes. What we really need to focus on is how to identify outcomes that are meaningful, and then to get payment for those outcomes, and to liberate and empower the front lines to go after them. So that it's not an issue of mandating, oh, well, if you leave the hospital, you have to coordinate care with an outpatient provider within a week. You tell the provider, you got to keep the person out of the hospital, off the streets and out of the jail all day long. That's the outcome that you drive for, and that's the outcome that you pay for. And I know that can't happen overnight, and my staff, one of whom is here as a commissioner, used to say, well, John, that's great. You believe in revolution, not evolution. But let's face it, we have a massive crisis in health and human services. And the only way to really get to a future where we can provide the care that people need is by incentivizing the work and demanding accountability for outcomes and not for process. And you could say, well, gee, what are those outcomes? Well, that's something that, like everything else, in my opinion, needs to be driven by the grassroots. The grassroots need to drive the grass tops. We have commissions at the local level. We have an amazing commission here. Can we not identify and agree upon the outcomes that we're going to spend billions of dollars going after instead of mandating this program, this report, that report? You didn't do that. You didn't take care of that chart properly. So 5 years later, we're going to take tens, hundreds of millions of dollars back from your department. And good luck managing your budget. We have to redesign our incentive structure, and I think there's a way to do it. I think the OAC has an incredible opportunity to leverage existing tools and its role in the state to get counties to go after outcomes and to optimize their contracts. The contracts that are written, frankly, are written for billability. You know, that's what runs the system. And that goes back to Washington, D.C. Really, at the end of the day, the agreement between the state and the Fed, that's not where these decisions need to be made. And we can't focus simply on process. So if you're a provider and you're asked, well, gee, keep this person who has a severe persistent mental illness off the street, out of the jail, out of the hospital, what are you going to do? Well, here's a contract, here's a lot of money. Well, I'm going to build a clubhouse myself. I'm going to leverage SB 803, which we really helped to pass, to bring a brigade of peers to keep people engaged. And we're going to achieve the goal of keeping that person not only out of those settings, but properly housed, educated, and hopefully employed or doing incredibly important civic work, because that's ultimately the driver of recovery. And if someone is on a recovery journey, they're going to want to take their medications. They're going to want to be stably housed. But that's not incentivized by our current system. At the end of the day, the vehicles that we have to build to do the work, which rely upon antiquated systems, fragmented funding, endless reporting, are never going to be able to move us to the destination that we all need to get to. And I've said this to my 5 bosses, the lovely supervisors of LA County. I've said it to Gavin Newsom and other people at the state. I've testified about it at the federal government, in Congress. You can't rely upon an old vehicle that consumes way too much gas and needs repairs all the time if you want to win the race. So those are the principles of what I would like to present, and I would like to suggest that the OAC think about ways to help counties upgrade the work that they're doing with their current contracts in their communities with tools like performance management, assistance with technical assistance, and also to figure out a way to get counties to develop contracts that are based on outcomes and where outcomes are paid for, simple and plain, and that we remove all the process and bureaucratic barriers that limit, frankly, the hearts and the minds and the dedication of our clients and our frontline providers. Thank you very much.
Thank you, Dr. Sharon. Chair Madigan-Weiss, I'll turn it back over to you for commissioner comments and questions.
I would like to invite my fellow commissioners for questions and comments. I'll start with Commissioner Bench.
Thank you. I have a couple of comments, but I'll be fast. First with Dr. Negron, one of your slides said the behavior in school is associated with eventual involvement with delinquency, and I just wanted to add on top of this, another layer is research that shows that teachers tend to blame black boys more than white boys for identical behaviors. So when we're looking at that slide, where there's another layer on it that we can add on top when we're talking about race.
I want to make sure I understood and clarify. So with the slide was not that the teachers accused more.
No, I understand that.
Okay, sorry.
I was
let me
just
make sure.
adding something onto
Okay.
it. I understand what you were saying. I'm adding to it.
All right. Could you
This is
repeat it? Because
another-
I
yes.
didn't hear you well. Sorry.
Your slide said that behavior in school is then associated later with delinquency.
Okay, yes.
Right. So what I was adding is that there's also research that shows that teachers tend to attribute negative behaviors to black boys for the same behavior that they'll see in their white counterparts. It was just a comment.
Oh, no, and I can expand on that. Not only with black boys, but Latinos, Hispanics, any minority. It's unfortunate, and it sometimes has to do with, in my opinion, like the socioeconomic status, how involved the parents are, and teachers are biased. You know, a parent who's more involved, they will be more likely to, you know, make concessions versus a parent who's not involved. And at Sable, where I was a psychiatrist, I was very aware of this. So I would meet with parents over the phone, like, you need me to call you at, 1 o'clock, 2 o'clock, because they're trying to work, they can't take off work. So depending, I mean, this is a fact, on your socioeconomic status, it's going to be a little bit more difficult. But it's not only with black boys, but Latinos and minorities in general, unfortunately.
Yeah, thank you. And then, Dr. Scott, I just wanted to reemphasize your comment that the warm handoff is so important. For my private practice, I do competency evaluations, and I meet so many people within the same year that I met before, and we have a conversation of, well, what happened? And basically, they're let out of they receive treatment while they're incarcerated, and then they're let out with no services, no housing, no medication, and then they end up back in the same place. And so many people have only received mental health services when they're incarcerated and have never gotten outpatient mental health services. So it's not just that there's not enough of a warm handoff. It doesn't seem to be any warm handoff when people are, at least what I'm seeing in LA County, when people are let out of jail onto the streets, there's no connection with services like there should be. And then I'm going to give everybody else a chance to talk. I'll come back if there's time.
Please, Commissioner Robinson.
Thank you. Just a couple questions. One was related to the warm handoff, and I think that is, I know in healthcare, that is a risk area of the highest magnitude. Just appreciate your opinion about what a warm handoff could look like. What do you see as an optimal warm handoff in behavioral health?
Thank you. I would completely agree. I think the warm handoff is something that we use. It's a jargon term we use within the field. It's almost a strong handoff that we need. And oftentimes, I feel like the patients or individuals who are accessing the system are left with a packet of information to do it for themselves. And I find that to be extremely challenging, even for myself to have a packet of information and know who to call when. Sometimes people aren't answering phones. You have to leave voicemails, have to take a record of what you've done and who you've called. But I would say, just generally in thinking about this, there really has to be more communication that occurs across our systems. Unfortunately, we don't have integrated even electronic health records across the system. And Dr. Sharon, I know you had spoke about working at the VA. I had worked at the VA many years ago as well, and what I had really loved about that system was their EHR system.
So just to put that in context, I started my career in the VA. I did my internship in 1991, and we had electronic medical records then.
Yeah.
So I was blown away yesterday in the tour that there's still paper. And I don't know how you can have continuity of care, how the next provider can understand what's happening with the case if you don't have that type of technology.
Can I make, oh, go ahead.
I would add to that. I think that the warm handoff has both components, right? Because even in systems that do have an integrated health records, I'm not going to mention any brand of an EHR, but there are some that, do a better job of pulling information from other systems than others. And then what happens is the opposite, is that you have this information overload. You have a doctor that's receiving a patient, 1 of 10 in an hour, and has to read through hundreds of pages. So I think the combination of a comprehensive, set of documents that you can refer back to as often as you need, or as you progress in your relationship with your patient, as well as a succinct doc-to-doc, hey, bottom line, this is what happened, this is what you need to watch out for, this is what I wanted to do but didn't get a chance to because the patient is ready for discharge, whatever. That collegiality is critical. It provides, it's a synopsis that you can get off to the races, so to speak, instead of like saying, oh my God, I don't even know where to begin searching through these massive amounts of medical records. Again, I think those medical records do need to be there, and they do need to be accessible to every provider. It's a pet peeve that I'm going to choose not to embark on right now, but the issue of lack of EHR and integrated EHRs is very near and dear to my heart. But I do think that warm handoff has got to be just that, very serious, very strong, but very warm, like, hey, between you and I, this is what's happening. This is the bottom line. This is what you need to watch out for. This is who's going to be your biggest ally. This is the family member that tends to decompensate this person. This is how you can integrate them. This is what we did that didn't work. That's going to take you a long time to find that in the records. So don't make that mistake again, and so on and so forth. So I would highlight both aspects of the content.
Yep. Obviously, this is an important question. You're getting people chiming in. I would say in the VA it was a lot easier because of the shared medical record. But even working in the VA, I ran mental health for the LA campus and for the Miami VA. when you have someone that's going to a contractor, they don't share the medical record. So what I actually would do as a psychiatrist when I did a lot of inpatient care was call a treating team, go visit the patient with the treatment team to talk it through. And in LA County, the term that I always used was live handoff. These need to be live handoffs. And it's one of the reasons why an advocate, a navigator, an ombudsman, a battle buddy if you're in the VA, which is like a peer, is critical, right? Oh, this is this person, and you're the new treatment team for this time being. This is what we've learned, and then to have a relationship that's ongoing with that client. Warm handoffs, unfortunately, are not particularly warm in our system of care. And I think if you require live handoffs, that would change.
Can I make one more comment? And just speaking to the fact that for individuals, sometimes living arrangements can be fluid. So you might try to contact that individual later and not be able to get in contact with them. So I would also say we know that family members like to be involved in their family members and in their care. And if there's ways to be able to have the family member involved, I think that's also very helpful because they might have the telephone means to be in contact or might know where that individual is when we're searching for them.
Commissioner Chambers and then Commissioner Carnevale and then Commissioner Roulette, please.
I just want to thank the panel. I learned so much as a behavioral health practitioner, someone that runs a business, and a person with lived mental health experience as a peer and have been hospitalized. So I just want to commend all the doctors up here for having just the empathy, the ethics, and unapologetic to tell the truth to Californians about some of the things that it's just we're kind of not knowing how to address. So I have some points. For Dr. Munoz, I wanted to just uplift the idea that you brought up, repeating of certain grades is the indicator in early intervention. As a mom with a son that got diagnosed with autism, and they told me it was late at 3, and I should have known it less than that, or 18 months. It's important, and it was but even though the teachers do have a lot of challenges, it was a teacher, a Latinx teacher, that believed in me and my ability to advocate for myself, and she had told me it'd never been done, but I believe that you can do it. So I just wanted us to uplift that even if the parents are involved, how do we bridge those gaps to have that advocate? Because it really is I probably do get a lot more resources because I'm there. I'm very present. And the more people, I like the idea too that you guys were noting that more people are moving into the inpatient and not everybody needs to be an inpatient. I think us as Californians, especially I still live in LA. I live 10 minutes away from downtown LA. My office is in downtown LA. I spend a lot of my time in downtown LA. For most people that know, that's ground zero, Skid Row, right? We know that people are sick, but I don't think that us as lay Californians sometimes understand that not everybody needs to be put locked up. And so I feel like as a community, Dr. Klein, I'm sorry if I'm saying your name wrong, but when you said the education of values of us having ethics, devotion, and commitment to being able to look at people with serious mental illness with respect and ethics, I think that needs to be a broader education, like you said, to the families, everyone, because I see the narrative that's continuing. As we look at people who are homeless on the streets, it's just lock them up and, put them away. So education is key. And I liked what you all were talking about, the warm handoff, with John bringing up the live handoff and the cost. Like I said, I recently went through another mental health crisis, and I struggled in general just to find resources. And I can imagine, I got so desperate, I went to LA County emergency, mental health place, and I got sent away because they said my blood pressure was too high, but I was I'm paranoid. I don't know, they were go to the hospital. I'm oh my, and I could have went off and did something. So just the idea of our mental health urgent cares, sending people away when I could have probably did something more serious was just It's just, I can just imagine. I have resources, and someone not having resources, I can imagine. And the idea of community mental health, we have not properly put the investments in our community mental health. So I think that I'd like to just uplift us really making the investments in our community, and of course, supporting the people that are really sick that need to be in the hospital, but also really making the investments to keep people whole. And I'm saying all this because I'm a peer provider, and all these things, and I don't just provide peer services, but we believe that peers are some of the lifeblood. Particularly in my last psychosis, it was peers that were able to take my phone calls in the middle of the night, were able to explain, like I said, when the medication was making me shake, or I became pre-diabetic. It was them sharing their stories, never telling me not to take my medicine, never telling me not to trust the doctors, just helping me bridge that relationship and therapeutic relationship with my doctor was so key. So I just really like to respect that doctors are up here acknowledging the work and the understanding of individuals with lived experience. And then I like the idea of the family is important. Like, we need to continue to train. I am also a vendor of the peer certification, the Medi-Cal peer specialist. So doctor, I really like your points about making sure people have that designation, family members and peers, because family members play such a role. My late sister, if I would have had more tools as a family member or support groups, I know Ms. Sheila had also mentioned, like Al-Anon, just anything. I couldn't even get a meeting or anything or have something. And so a family member is really important, and a trained family member is really key. So just continue to uplift it, what you guys are saying. And then just to the last point about John's on FSPs and the potential, thank you, John, for your leadership, and others like Karis Myrick and other folks, and getting SB 803. But as we know, SB 803 has many implementation challenges. And so peers are currently not able to support the full Medi-Cal provision, in addition to mild to moderate and severe and people with mental illness. So I really welcome, just with FSP, the idea of integrating the lived experience in that model. And then also, as a full behavioral practitioner, I've talked to so many clinicians. I've actually hired a recent clinician at my job who left the FSP program, and the number one issue that they had was lack of support, burnout, and the billing, the billing didn't match. And so I believe that that's that's pretty common, and I just really respect that you're trying to identify in your colleagues outcomes that are meaningful and incentivizing the work. I think there's an HCI grant that does that. It's based off outcomes, and you get paid off outcomes. So I think HCI is doing something, but just overall excited. But I'm skeptical of us being able to do what incentivize this under the Medi-Cal model. So I am going to be watching you, because this will be transformative to our system if you can do this. Thank you, and I talked a lot.
Thank you, Commissioner Chambers. Commissioner Carnevale, please.
Thank you. My fellow commissioner should have been on the panel. That was equally interesting. Thank you for everybody. A comment and then a question. My comment goes back first to Sheila. What a richness of shared lived experience, and there's so much there, but the thing that jumped out at me is she was much nicer than I would be. She said it's nobody's fault, and in one sense she's right. That's my experience. Everybody's working really hard, but if it's nobody's fault and the system is still broken and not going anywhere, then to me that means it's everybody's fault. It's up to us to fix it, and we're really not fixing it. So I remind, this is really for my fellow commissioners, I applaud what Dr. Sharon has talked about relative to outcome-based system, and I mentioned this at the last meeting where we talked about our strategic plan, and that's sort of the third, I think it's the essential third piece of the strategic plan. We now have a framework in place. We still have to finish putting data in place that underpins that strategic plan. And then we've got to put these outcome-based measurements in place, and we've got to model this for the state, because that's just good government. And what we have right now is not really good government. So to my question, I have a particular interest in the juvenile justice system because of a new organization the state created called the Institute of Law, Neuroscience, and Education, which I'm part of. And it seems to me the juvenile justice system is just a precursor to the rest of this. And of what I know about it, the state has kind of deconstructed it, but hasn't completely reconstructed it. And so I'm wondering what any of your opinions you have about our current state of the juvenile justice system, and what are we missing? What should we be doing? What does it mean to this broader conversation? Any thoughts you have would be really appreciated.
I smirk because I'm going to try to keep it short. I can go on for the rest of the afternoon on that one. In keeping it short, to make a comment about the system, one of my pet peeves is we blame the system, but like you said, we are the system. So what are we doing? You know, it's very easy, the system, but we are the system. So what are we doing? And in terms of juvenile justice, one of the biggest challenges, and I'm writing on this right now, is we move to a very cognitive behavioral-based model, right? We're going to teach these kids aggression replacement therapy, and we're going to teach them, you know, all these things, but not all of them are cognitively at the same level. So it gets back to, you know, how do they learn? So we have these very nice therapies, evidence-based therapies that have very beautiful outcomes, but they're with people that meet this criteria. So I do clinical research. They look for the unicorn. Of course the outcomes are going to be beautiful. You know, we're not being inclusive of everybody. So that is one of the issues, and the kids are set up for failure. And one of the problems also is this continuity of care. As soon as they get into the juvenile justice system, I start telling the parents, where's follow-up from day one? You're leaving in 6 months, where are you going to follow up? I'm like a broken record. Where are you going to follow up? Where are we going to get these medications? Are they going to have enough medications? They can't leave if they don't have an appointment. And they're inappropriately placed because they just want to put them in a facility. So they're not really looking at their, what type of services they truly need. So then they're not cognitively intact, they don't get the program, they may not learn it, so then they reoffend. Some of them do very well, but I think, in my personal opinion, that's part of the problem. And they're not addressing, for whatever reason. Right now in one of my programs, there's a lot of children who are from the Department of Children and Family Services. So it's not the family. It's easy when you have an intact family, you know, that wants to be or can be involved, versus the one who already has difficulties, the trauma. So it's a very many different things to keep in mind for these children to ensure their success and decrease, you know, recidivism.
If I might add a couple of things. I think it comes back to it, and I applaud Dr. Negron's sort of vision of like, yes, CBT is a good therapy. It's a convenient therapy from a billing perspective. It's also good for the right population, the patient who's truly eligible and stands to benefit from it. It's a good therapy. But for everybody else, it's a conveniently billable therapy. And so it has become the de facto therapy, and we have to stop treating people de facto. Yes, there are some common threads. There's one person with schizophrenia has some common features as another person with schizophrenia, but guess what? They're different people, and they might have different needs, and they have different circumstances and different experiences and different responses to treatment and different everything because they're different people. So I think that this treating everybody the same has value in a fundamental fairness type of way, but we take away from that value when we just take away the unique identity and the unique needs. And that brings me back to my point of like, we have to favor specialization. We have to, once again, come back to, there are people that are experts for a reason, and that counts for something in this field. The field has advanced tremendously, And a specialist or a subspecialist can deal with things that a non-specialist or non-subspecialist cannot. So I think that there's a lot of that. I think there's also a lot of us repeating the same mistakes again. We deinstitutionalized everybody in the 1970s without enough community supports, and we did it again with the juveniles. Because we want to hope for them to get better, because we don't want to see them deprived of freedom, because they're kids, right? And I get that hope is super important. I vote for hope. But it's not everything, right? Like, it's not everything if you don't pair that with the appropriate intervention. And last but not least, I also want to make a plug for, like, we have to be aware of the role of addictions in our juveniles. And that is an elephant in the room that people just don't want to talk about or don't want to talk about enough. It's easy to talk about an adult that is using substances, multiple. But kind of what Dr. Scott was saying, the kids that are using heavily at 8, 7, 6, it's a prevalent issue, and it's just not addressed directly. It's addressed as a consequence of the behavioral problem, or, you know, experimenting with drugs. No, these are brains in development, soaked in intoxicating substances. And so unless we start treating addiction in juveniles very aggressively and very sort of like in a dedicated manner, I don't see how we get ourselves out of this hole.
Just to, go ahead.
I'm sorry, just to go off that real quick, and then it goes to the trauma, right? Because when you ask the kids, they're very honest. They'll tell you, my mom gave me drugs, or I was using this, what are you using it for? I would say that's 7, sometimes it's being mild. Some of the kids will tell you, I started using at 5. My mom sold me for drugs at 5. So you have to ask. And it's like in the Army, whatever, don't ask, don't tell. It's more comfortable for the clinician not to ask. So you have to be very comfortable asking these questions to get to the bottom of it. The kids are very honest. They will tell you. Sometimes it is to treat symptoms, and sometimes they just like it. I've had kids tell me, I just like the way it makes me feel. There's no issues. But when you really get into it, we also have to look at trauma, which leads to substance abuse, which then we go on from there. Thank you.
Yeah, well, I would agree. And I guess, you know, name your pipeline. We have to be identifying red flags really early, looking at life circumstances, not, you know, pathologizing prematurely in order to have the kind of impact that we need. And I mean, I've been talking about people, place, and purpose as community for a long time. But I would say if those are the things that we got our eye on the prize of community for an individual and make sure that they have an opportunity in those different domains, then we're going to be doing good things. And if we're, again, paid for making sure that an individual has them and is thriving in them, it's a new day.
Thank you. I am going to ask Commissioner Rolette, did you want to make a statement, please?
So I'll make a couple of comments and then a question for Dr. Sharon. First, my comments. I've had the unique privilege of working with people who've transitioned out of Napa State Hospital pre it being a forensic facility and post being a forensic facility, and they describe what their needs for community support in the same way in many cases that I would describe them, with the exception of really being insightful about the need to mitigate the factors that cause the trauma that you're describing. And those factors that cause the trauma, wanting to make sure that they were ameliorated when they return to the community. And that people are insightful about that. And that is not dependent upon having a psychiatric illness, that people can do that. And then secondly, this notion about support and navigation. And so for the staff, it is, Toby, I think, so important that you are highlighting full-service partnerships, because I do think and have experienced that perspective that's provided around community supports and full-service partnerships is often best articulated by people with their own lived experience. In my own experience, people with lived experience that included being in state hospitals, that were able to encourage people in state hospitals that you can live successfully outside of being identified as a consumer of mental health services, that you can have an identity in the United States that is not, again, surrounded by all the encumbrances sometimes or stigma associated with being diagnosed with the psychotic disorder. And hearing that from them was very empowering. However, we are in this fee-for-service system, in my opinion. And how we get to value-based care, or what the OAC's role is in supporting value-based care, is my question for you, Dr. Sharon. Because I agree with you. Let's pay for what works. Because some of the things I just described, we don't get paid to do that. We get paid for putting down the interventions that are associated with CBT that mitigate some of the negative symptoms associated with all the things that you all have described. That's all we get paid. And we end up pursuing that versus, as you said, a clubhouse that involves having people with lived experience, family members, and a variety of different perspectives integrated into, and as I think somebody else said, into a clubhouse that changes the trajectory of a person's life. How do we get there? And what recommendations do you have that the OAC might advocate that we get there? Because I agree with that.
Well, thank you very much for your comments. One of the things that was really great about the county behavioral health system in California is the Innovation Fund. And I really, as I had said earlier, I think I had about 10 innovation projects, and hopefully most of them are getting traction. But the ability to use innovation funds to pay for outcomes, I would say, to contractors is something that really ought to be leveraged. And I don't think that it is, to the degree that it could be. And, I actually was involved in helping write a report about the importance of not just performance management, which I don't think the counties do that well. It's not easy. I mean, we tried to do it. But also outcomes-based contracts. What do they look like? They have been used in other parts of the world. And innovation money, in my opinion, is to be used for that type of payment. In other words, when we think about, and the goal, look at what happens when a kid with trauma who doesn't have community ends up in the system. How much is that going to cost over the course of that person's life? How much is it going to cost for someone to spend their years in LA County Jail? That money ought to be reallocated to pay great providers like yourself to focus on the outcomes of a life and the life trajectory, because it will cost a third as much, and what you'll be doing is helping someone who's going to have a lifetime of trauma experience well-being. So with the Innovation Fund, I would say you can begin to demonstrate that return on investment, the humanitarian return on investment and a return on investment in terms of costs. Because if you are delivering a certain, right now, like I was saying, it's about billability, which you're repeating. But how is a menu of services and codes going to help a person at the ground floor care for another and help them facilitate deal with the challenges of their lives? It's not going to happen. And I think until we have the courage to basically push back on the whole idea of fee-for-service and begin to push with the waiver towards outcomes as a state and change things like IMD exclusion, we're never going to get there.
If I may expand on that a little bit for fee-for-service, I think pushing back, we're expected to have certain words or certain things. All of us who work in this know this. So if you don't write this word or you don't say it's this, you don't get paid. And I think with that, we miss sometimes the true cause of what's happening. So I think as clinicians, we have to feel free to document your true, not be dictated by the system, and document things as they are. If I get paid, I get paid. If not, I want to make sure this person gets the right treatment.
Thank you. We're going to, yes, Commissioner Mitchell, and then we're going to wrap it up.
Yes, this will be quick, because there was so much beautiful information here. And thank you, Commissioner Rolette, for bringing that up, and Dr. Sharon for addressing the performance outcome, performance management piece. Because again, as a person who has utilized the services and then still been in the business and seeing clients, we're billing hundreds of thousands of dollars. And, it's shameful, but I do question, how much are we really improving their lives? And the question that I ask, are we standing in the right place to do the most good? Are we standing in that place? And so how do we do that? And I think as a commission, to Dr. Negron, you just said, we have to push back, because you said, and I agree, we are the system. And I'll go to my grave saying it, I just don't understand why we continue to do the same thing and think we're going to get a different outcome when we put systems in place that build for outcomes, not tasks, not interventions, that maybe they're working, maybe they're not, even though they're supposed to be best practices. It doesn't make sense. And all of this education and smartness in this room, and we're still doing the same thing. It just doesn't make sense. And that's why I'm just asking for that poor family, that lay person out there whose life needs to be improved. And we're seeing them weekly, billing them weekly. And Dr. Sharon, because I've seen you many times at this, these meetings, and I get so emotional when I come to LA, and I just see the devastation of lives, and we're still doing the same thing. And yet we're continuously billing, we're continuously, doing what we do. But are we really standing in the place where we can do the most good and affecting the lives? The idea of performance outcomes. It's so simple. And yet, and again, to Dr. Klein's point, and Dr. Sharon, you can have it after this. Dr. Klein, I love that, the peers are such an important part, but peers do need to be specialized in different areas. And we have to use our peers, we have to use our navigators, we have to use our lead care coordinators to help with those warm handoffs, warm, hot, cold, wherever you call them. But we've just got to do better. And we can, but it has to be that emotional connection to want to help someone's life be better. So Dr. Sharon, you were about to say?
I think we're over time, but I have a lot to say.
Thank you. We're going to go ahead and move on at this time. So if you would like to respond to that.
I just, one of the things that I did do in LA County is I got money from a generous gift from the Balmer Foundation to do incentivized outcome-based contracts for FSP 2.0. And you guys, I think, got behind that, and you did it for other counties. You helped support it, but it didn't lead all the way. We're 20% of the way. So I think, just to keep it simple, we need an FSP 3.0, and that 3.0 needs to be driven by simple outcomes. I mean, what I always said, and I said this to our governor, I said, if you want to go after the homeless crisis, let me figure out, and we did this with UCLA, how many people who are homeless in the streets of Los Angeles County have a chronic psychotic disorder. It's actually 10%. And then let me decrease that number by 10% per year over the next 5 years. I'll tell you how much it's going to cost me. Pay me. Hold me accountable to that. Fire me on live TV for that accountability, as opposed to these ridiculous audits and then clawing back money. And in the process, how many people count beans to do those audits? You know what I mean? Like, this person's actually no longer on the street a year later, and maybe they're even employed and they're reconnected with their family of origin, or they have other kinship relations. Judge me on that.
Thank you. Again, thank you, panel members, for being here. We appreciate your time and expertise in informing this commission. And again, I would like to thank our parent, Sheila, for your time here today. At this time, we are going to move on to members of the public, comments from the public. So if we can have members of the public may request to make a public comment on agenda item 6 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Are there any public comments, Lester? Please raise your hand now as the queue will be closing.
Chair, we have 3 public comments, 1 in the room. Stacy Hiramoto, please go ahead.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition, and I want to thank the commission for having the panelists. They were very insightful, very knowledgeable, and I could tell they were very committed. I guess I was a little confused, though. The title of this panel is Strengthening Early Intervention to Reduce Criminal Justice Involvement. And the panelists, for the most part, except for maybe Dr. Sharon, were all professionals, again, great professionals, who were working with people who were in the criminal justice. And yes, of course, their knowledge and their insightful thoughts are important, but I guess what I felt was missing was professionals who work with people in the community before and think and believe that their programs prevent people from going into the criminal justice system. And I would say that some of those programs exist today, and their programs are paid for by PEI, or they may be CDEPs. And I think I was in the ladies' room, so I'm sorry, but I think there was supposed to be a consumer, and there was not a consumer. So I really feel that that consumer perspective was missing. So I really appreciate the comments of Commissioner Chambers, because I think that is what's important. And I do want to give a slightly different perspective about the backfiring of requiring somebody to be dangerous before, being forcibly treated. I think we have prevented so much harm and trauma, if you talk to consumers, from people getting forcibly treated when not necessary, when not dangerous, and the trauma that's prevented. I think they would say that that is a trade-off that is worth it for people, again, before these laws, when people could be forcibly treated very easily, and the harm that that's done to consumers over the years. And then the other thing that I think that was missing, that I was very glad that Commissioner Bunch brought up, was the impact of race and ethnicity and other factors on whether people are hospitalized versus incarcerated. And I did not see that perspective here. And I think that's important. So again, trying to put the aspect of race, which we cannot get away from in this state. And I didn't see that in any of the presentations. But again, thank you for the panel, and I appreciate the ability to make public comment. Thank you.
Thank you, Stacy.
Next we have Laurel. Your line is open. Please go ahead.
Good morning. Thank you very much. I have to say I'm a bit sad after the panel's discussion, but it's not a surprise. One issue that was not addressed and actually got me into this work in the 1980s in Minnesota is the issue of how people with limited English or non-English speakers are treated and navigate the system or don't, and the difficulties with that. At the time, the main concern in Minnesota with the national project were Vietnamese refugees, Cambodian refugees, Hmong refugees, and Laotian refugees and Cuban refugees coming into the United States. Well, now here we are in California. I'm with Muslim American Society Social Services Foundation. We're very concerned with Afghans nationally and locally, as well as Syrians and Iraqis. And so I would like to know from the panel, all of whom have some experience, what do you think has gotten better and what do you think needs to be done so that the racial and ethnic and linguistic mental health disparities can be addressed? And I forgot to say that I'm with Remco too, and Stacy is our executive director, and I would almost always support what she brings up. But my main concern are the people whose lack of English or absence of English and how that affects their journey in the U.S. through the mental health system. Thank you.
Thank you, Laurel.
Okay, we have one last public comment. Richard, your line is open. Please go ahead. Richard, I'm making you co-host. Please go ahead and use the unmute button to unmute. Richard, if you're able to use the unmute button on your Zoom app, please do so.
Richard, we're going to invite you to please send us an email. We are not able to get you on. So if you could please do that, we would appreciate it. Thank you, Richard.
All right, and that was our last public comment, Chair.
We are now going to pause for a lunch break. We encourage the public in the room and on Zoom to also take a break. We will reconvene at 1:30. See you then. Thanks. Welcome back, everyone. I hope you had a nice lunch break. We will be moving on to our next agenda item, the Universal Screening Report. The Commission will hear a presentation on Phase 1 of the Universal Screening for Children and Youth Report as required by the supplemental reporting language in the Budget Act of 2023 through 24, and will consider adopting the report. The goal of this report is to inform the legislature's future budget and policy decisions related to universal mental health screening of children and youth with the goal of reducing adverse health and life outcomes later in life stemming from unaddressed mental health issues. We will hear from Kaylee Patterson, Research Scientist Supervisor. Kaylee, welcome. Please go ahead with your presentation.
Thank you, Madam Chair. Could I ask for just 10 seconds of your time while I set up?
Absolutely. And Commissioners, if you'd like, you can refer to the report. The full report is in your packet.
Okay. Thank you, everyone, for the opportunity to be here today and talk about the Commission's Universal Screening for Children and Youth Project Phase 1 report. Today, I'm going to walk through sort of the background of the report and the project itself, give a little context of kind of what's happening currently in California and why universal screening matters, talk about our process and activities and methodologies for the research, and engagement that informed the report, and then I'm going to highlight some of the key findings from that are presented in the report itself. So the 2023-2024 Budget Act included a request that the Commission engage in a study and develop a report on opportunities for universal screening for children and youth, with an emphasis on opportunities in school settings. This is part of California's broader initiatives to address the need for enhanced behavioral health services for children, and really supports the broader learning and ecosystem of prevention, early intervention, and equity-centered approaches that several of the state's other investments, such as the California Youth Behavioral Health Initiative, among others, are really focused on. So as the state, builds out this framework and ecosystem for youth behavioral health, there's a growing not only recognition of the just immense importance of schools in this continuum of care, but also a growing curiosity around universal screening as a tool to support that continuum. So the legislature's request includes a summary of research tools, best practices, and costs for implementation of universal screening practices. There is an interest in understanding the landscape of existing screening practices and barriers in California, and also to provide some type of guidance to really inform progress in this space. So I'm going to spend a little bit of time just talking about our process. Really the goal of this project and the report is to address gaps in knowledge and practice related to universal screening for youth. And like I said before, in support of California's broader goals and investments for youth behavioral health. Under the leadership of Chair Madrigal-Weiss and in collaboration with the legislature, CYBHI, and the Department of Healthcare Services, staff have been conducting research and community engagement activities to inform this project and report. We contracted with the university, a group of researchers actually from the University of UC San Francisco and UC Irvine to support a comprehensive literature review. So that is what this report today will primarily focus on. And that includes a summary of existing research that is already, a lot has been done in this space, so really trying to summarize that in a way that's useful for the legislature. And in addition to the literature review, our research will include a statewide survey of screening practices in schools. I'm going to talk about this a little bit later, but there's been this recognition that there's really no mechanism to systematically report or collect information on school-based screening, mental health and behavioral health screening practices, at least not to the degree that would be helpful to really answer the legislature's questions. We have also been doing various outreach and engagement activities with key informant interviews, public meetings, to really understand a spectrum of opportunities and the perceptions and needs related to universal screening. We are doing a series of site visits. We've done 2 so far, one in Chula Vista, Feaster Charter School in Chula Vista, and another at Sonoma Valley High School, really to kind of zoom in closely on some examples of school-based universal screening, both very different examples, but still meet the definition of universal screening, which I am going to get into next. So stay tuned. So in addition to really project-specific activities, staff are also drawing as much as we can from the areas where universal screening intersects with a lot of the other commission's initiatives. So, the most obvious being the MHSSA. We have engaged with their work group and have also been just really tapping into the community that's already been sort of built out around that initiative, and also drawing from the learnings there. And in addition to that, really, again, so thankful that we have two commissioners who've just, already are working so closely in the school mental health space, and so just been really grateful to have that kind of leadership and also support, and also have been learning through sort of parallel efforts around screening related to dyslexia that's happening at the University of San Francisco, which really there's just a tremendous overlap when we're talking about, the best practices for a universal screener in a school setting. So the final report will be submitted in two phases. The first one, which is the one we're reviewing today, is, like I said, a literature review summary. The second one will be presented to the commission in July, and hopefully submitted to the legislature in August. That will include the literature review in addition to our findings from the statewide survey I mentioned, and really more of a complete landscape analysis of practices, and also really trying to understand where the gaps are and the barriers, and to really inform where we can kind of lean in to make progress. So I'm going to get to the report itself, but I do want to take a minute to just make sure first that we all have a really clear and shared understanding of what we mean by universal screening. So universal mental health screening in the report is defined as a systematic and proactive assessment of social, emotional, and behavioral health needs that's provided to all people within a given population or setting. In this case, we're focusing on schools, but recognizing a population could be as small as a classroom, or as big as a district, or even a whole state, I guess, technically. But so population doesn't mean the whole world or universe. It's really dependent on a particular group of people of focus. It is considered an essential component of a broader continuum of promotion, prevention, and early intervention. And so I say that because it should never be talked about separate from that broader structure that it informs, but also depends on to work well. So when we talk about screening practices, it really relies on having that robust continuum of care. It's also distinct from other types of screening. So we found that there's a lot of confusion sometimes, where it gets kind of confused with screenings such as the California Kids Survey, which does indeed do universal screening, but that screening does not inform or is not able to identify individual needs or risk. Also, it is not the same as assessment or even targeted screening for diagnoses, which are also very important pieces of the care continuum, but not necessarily the goal of universal screening. Those strategies can benefit from universal screening by casting a wider net. We can identify a range of needs, but universal screening is unique in that it can inform population-wide or school-wide programming and strategies that benefit all students, and really create a culture of wellness and promotion of the school, in addition to identifying individual needs as well. So I'm going to talk a little bit more about that later. So you'll have to excuse my poor, I'm not a, graphic designer, but I wanted to make sure we spent a little bit of time talking about kind of how universal screening fits within what we call a multi-tiered system of support. This multi-tiered system of support, or what's referred to as MTSS, is a model I'm sure a lot of you are familiar with, especially if you work anywhere close to the school system. But it's a model that's been endorsed by schools in California and elsewhere as really this gold standard of how to basically do what we're more in mental health, what we call primary, secondary, and tertiary prevention. But basically, it's providing a range of services and supports and programming to meet a variety of needs, hoping that most will be happening at what we call Tier 1, so it would be school-wide. A little bit less in Tier 2, which is more targeted for people who are students who are identified with higher risk, and then, of course, Tier 3 for those which we will always have someone, I think we heard this today, that will need intensive individualized care. We want to make sure that we have the resources available to do that. So just being really, the structure allows for more sort of triaged processes to make sure that people get the care they need early in a way that, is effective for them. So universal screening fits into this model. As I said before, it kind of casts a wide net and to really, most of that data would inform what we call Tier 1. Some would inform Tier 2, but that would also inform if there's any need for additional assessments or screening that would then triage to actual intervention. I want to mention too that this according to the California Department of Education, who endorsed this model, they themselves say that universal screening is in fact a core component of this model. So just something to keep in mind. Oh, sorry. I'm about to get into the report itself. I do want to share with you, though, a little bit of some of the kind of preliminary findings, or kind of the current landscape that at least, that we're aware of, and that going into this project were really kind of apparent right away, and which have really helped guide the goals of this project itself. So, first of all, I mentioned this before, all you have to do is Google universal screening or go onto PubMed or any search platform. There has been so much work done in this space on universal screening, which is phenomenal. And there are tools and toolkits and best practice guides, and some of that is included in the report, and I'm not going to focus a lot on those specific tools in this presentation, but just to know that there has been a lot of work done. So I think the task at hand is less about demonstrating that screening is needed, or that that in tool development. Not to say that we can't do better, and I'm going to talk about that in an equity sense later. But that really, it's how do we get these tools into the hands of schools and others who can use it to really strengthen the work that they're doing and help them serve children better. So another kind of overarching narrative in this space is that even though universal screening is recommended by a lot of authorities in mental health and education, there's a hesitancy and almost a fear that schools have expressed in terms of if we start screening and we find things, then we have to do something about it, and we don't know if we can. And it is a real concern because schools are liable, and so it's valid. There are concerns around capacity, need for training, and really, the need for infrastructure to support the screening itself, but also what happens afterwards. So how do we use that information to inform programming, but also get do follow-up and triage and linkage to care. Other consistent barriers, I already mentioned liability, but also concerns around how to navigate consent, confidentiality, data protection. There's concern around parent buy-in and kind of a stigma related to screening itself, and of course, just ongoing uncertainty of how universal screening might be funded. So there's also a big barrier in this space is inconsistency around universal screening terminology, which is why I really wanted to make sure we started with a clear definition of what it actually is and how it can be used. And I mentioned kind of as it gets confused with other types of screeners that focus on either diagnosis or don't result in treatment. It can not only, it sort of reinforces some of the concerns that schools have around, capacity and liability, because it inflates kind of the degree of needs that it is intended to really capture. Another really big challenge, and I mentioned this before, is that, we know sort of anecdotally that screening is happening in California. We have, for example, MHSSA grantees, some of them are doing mental health screening. We've been to site visits, and so we know it's happening, but there's no mechanism to access that kind of data. And so it's kind of a missed opportunity because we can't learn from what's happening now, even though we know it's happening. So despite these roadblocks, though, California in many ways has really already begun laying the groundwork for a lot of this. And I kind of started off talking about the California Youth Behavioral Health Initiative, which is doing a lot in terms of infrastructure, workforce and resources to support school-based mental and behavioral health. And some work streams there that are particularly important are the new fee schedule, which would allow, it makes it easier for schools to fund school-based mental health and behavioral health services, and that fee schedule actually includes screening. Also, the work being done with wellness coaches might be one way that schools could address capacity concerns for responding to screens. I mentioned also the MHSSA in general is already kind of started building out the necessary infrastructure and partnerships that would support something like universal screening itself, but also the component of the MHSSA funding or grant that would support screening planning is also something that's just happening, potentially happening parallel to this. One more thing, or two more things actually. The MTSS model that I mentioned, California is putting a lot of money into scaling that model in schools, really encouraging LEAs to establish and align school-wide data-driven systems of academic and behavioral health supports, and that includes universal screening. One more thing, and this is sort of less specific, but something to pay attention to that, under Prop 1, the behavioral health reform, there's a unique focus on population-based strategies and an opportunity to kind of shape what those, how that new, how that's implemented. And should that pass, this is one area where maybe universal screening is part of that approach. And I want to make it really clear. I've talked about this before recently in a presentation, and I got feedback about, well, we don't want to signal that we're adding another sort of area of competition for this already scarce resource, because there is a lot of concern around that. And I want to be clear that any other population-based strategy would, it wouldn't be like screening wouldn't be separate from that. It could be part of it. So, for example, community-defined evidence practices, which are a really exciting area of innovation in California. there might, and I'm going to talk about equity-centered screening, and that might be one area to build out on community-defined practices through really enhanced screening efforts. Okay. So I'm going to jump into the report itself. As I mentioned, this one specifically focuses on just the literature review. It's very technical. I'm going to do my best not to get too much into the weeds, but just really highlight some of the key themes and best practices that are talked about in the literature review. So the first section focuses on just kind of the evidence to support universal mental health screening. I've already talked about kind of how it sits within the multi-tiered systems of support and how it can be used as a tool to really guide that programming across each tier. And I've also talked about how it's distinct from other types of mental health screening. Also that, a lot has been done in terms of tool development, and there's a really comprehensive list of screening tools in the report that you can reference. But I really want to point out that there's really no one-size-fits-all when it comes to universal screening. Like any best practice when it comes to prevention and early intervention, you're going to have the best success when the strategies are tailored to the needs and characteristics of whatever population they're geared to serve, and that they really should be goal-driven. So universal screening as well might look different depending on the school and the needs of students and the goals that have been identified. And so there are ways to kind of quantify how, screening strategies can be identified to support that goal. And so we look, a best practice would be to consider appropriateness. So is it measuring the construct that is linked to the outcome that the school has identified? Is it technically adequate? Meaning, has it proven to be specific and be able to discriminate from what you want to see and what you don't? So just standard kind of technical ways of vetting tools, and then perhaps most importantly is the degree of usability. So even if the research says that it's reliable and valid, making sure that it is something that can be easily used and by whether it's school staff or whoever is using the screening, that it's accessible. So the next section focuses on best practices for implementation. So there's, we've heard this a lot, especially through our engagement, that so much of the work for screening really happens before the screen. It includes, like I said, identifying that goal, doing really robust resource mapping, developing protocols around, for responding to screens, kind of really having a set plan how to address consent and confidentiality, some of those things. Just a lot of work needs to be done. And also really building that trust with the school, with teachers, administrators, parents, students, really to get that buy-in, because actually that's really a key component to the effectiveness of universal screening. Timing and frequency is important because, especially as you're thinking K through 12 population, the best practices recommend that screening should be done routinely and at least twice a year to kind of show maybe potentially changes in need and hopefully improvements through your programming, but also to really capture kids where they are as they develop, because there are different risks that emerge as they age.
Kaylee, I'm going to ask you to, if you could please move us to kind of the action item. And the only reason I'm saying this is we have commissioners that are going to have to take flights, and they still are a little bit away, well, we're away from the airport. And so if you could get us kind of to the action item, and we have the report in the packet. So if you could just let us know what our action item is for this. And then, of course, if our commissioners have questions or comments on the report that was sent to us, if we could do that. We just don't want to lose the quorum, and we still have 2 more items to vote on.
Sure. So the action item would be to adopt the report and approve it for submitting to the legislature on March 1st. I believe our legal counsel has I don't have this.
The what?
And again, this is phase 1 of the report.
Phase one
So
of the
it's
report.
just, it's taking us to phase 1. It's a literature review. It's giving us the definitions, kind of what Kaylee has found. And just because I've been working with the group, I think they've done a really excellent job in identifying tools, patterns, definitions of what we have seen. And we're still going to learn more. So phase 1 of it, it is moving us forward on this. And I just want to personally thank the team, Kaylee's leadership, what you have done, and our partners with UCSF and UC Irvine, who have done an excellent job as well. But at this time, I would like to entertain any questions or comments from our commissioners regarding this. Please.
My quick question was, Kaylee, is this, so I know this is round 1 because the other part is going to come out later. So is our goal to, once we give this to the legislature and then it's going to inform policy, is our goal to try to put universal screening in all the schools? Is that what we're trying to go for?
Not necessarily. It's to provide the necessary information to make an informed decision about whether or not that would be appropriate, or if we're ready. So not just looking at screening, but again, kind of mapping out how it fits into this broader infrastructure that's being already, it's happening right now. I would, so anyways, that's the goal.
Okay.
Thank you. Any other questions or comments? Please.
I would like to move that we adopt this report for the legislature for phase 1, and simply say, because I spend a lot of time in this area, as many of you know, that, everything we hear is about doing early prevention and early intervention, and this is kind of ground zero for that. So I think we do need to lean in heavily to this, and this is a great beginning.
Thank you, Commissioner Carnevale.
I'll second.
Thank you, Vice Chair Alvarez.
And I just want to say one thing to Kaylee's point about, are we ready? I thought what you show, what we have on the paper really describes the essential commitment that we have to have as a community to respond to that screening. So I really appreciate how that came out clear in what we're presenting forward to the legislature.
One other comment.
Yes, please, Commissioner Robinson.
Before we take a vote, I really do appreciate some of the comments you made about the potential for stigma that could be associated with this. I like hearing a sensitivity around parents' rights, that they have a right to opt out. I think that's important. And I do want to double click on, when you start this type of screening, there is some responsibility that goes along with it if you find something. So, very much in favor of moving this forward, but I want to make sure that those conversations around those issues continue as we get closer to implementation.
Thank you. Commissioner Rolette, please.
So I'm going to add, based on what Commissioner Robinson just said, and I'm going to try to articulate this very succinctly, if the absence of universal mental health screening is causal to poor outcomes for Black and brown kids, how do you mitigate all the things that Commissioner Robinson said so we can get universal mental health screening more broadly accepted and established, i.e., the risks that LEAs say that they take if they identify problems and don't address them, and then the stigma associated with what Black and brown communities experience when they pursue mental health services.
Thank you.
I would just like to add, I'm all for this universal mental health screening, and I would like to add, though, that we also consider that we screen for strengths, for resiliency, for protective factors, and not just give lip service to it. I mean, I think sometimes we're deficit hunting and we should be treasure hunting. And a lot of these young people have a great deal of treasure and have a great deal of resiliency. And instead of us searching for deficits and then doing something for them or to them, let's learn from them what are their strengths, what are their reservoirs of resiliency, and they can teach us, and we can learn from them. So I just hope we can balance and go treasure hunting as well as deficit hunting.
Am I allowed to say anything to that?
You can respond, absolutely.
Because one
Thank you.
of the report includes this, and I didn't get to it in the presentation, but the point is too that screening is a tool for addressing disparities at the end of the day, done well. And if it's done in a way that's equity informed, in that it is used to, earlier we heard how, Black and brown people are overrepresented in, disciplinary strategies at school, overrepresented in special education, all these sort of catch-alls in that system where people end up when they don't get served earlier. And bias involved in, teacher reports or, behavioral ways of identifying needs is removed when you do something like a universal screener. It is a tool to drive equity, if it's equity informed. So to your point, and the strengths and weaknesses, or strengths piece of that is so critical.
Thank you, Kaylee. Okay. Thank you. Seeing no other questions or comments from my fellow commissioners, I am going to then ask that we move to public comment. Members of the public may request to make a public comment on agenda item 8 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Are there any public comments? Lester, please raise your hand now as the queue will be closing.
Yes, we have 2 public comments. Steve McNally, your line is open. Please go ahead.
Thank you very much. My name is Steve McNally. I'm from Orange County. I am on a local behavioral health board with Welfare and Institution Code responsibilities. I'm going to speak as a family member of someone with schizophrenia. In our county, we have a psychologist with 25 years of experience who put social determinants into a mental health screening, and it was funded by managed healthcare. And what they found is that approximately 8% of the students, regardless of whether it was a wealthy or a poor, relatively poor or middle income school, all had the same suicidal ideation. And as a person who, I understand, I guess, the liability, but to let someone struggle who could have known that they could have gotten help and not to help them because of liability concerns seems wrong to me. And what they did was they created crisis response around the schools that they were testing at the time. Another thing that would be interesting to me is on the, on the treasure hunting comment is, we do physical testing at 5th, 7th, and 9th grade. And then the other trigger points would be graduating high school. So if you were to do even ACEs aware or some kind of screening where you could track it through, that might be helpful, and that could be easily, well, maybe not easily, that might be able to be legislated on top of the physical screening that's already existing. And then the other thing is that, God, I lost my train of thought. I'm sorry. So we have several people on our boards in different cultural communities that have more denial than others, or maybe more adverse to embracing mental health screenings or even the concept of mental health. And I think tying this to addressing the stigma that exists in those communities is really important if you want to raise the amount of participation and acceptance. And I think all communities have denial because denial works until it doesn't. But relative to people, certain communities, as we all are aware, have more concern about even dealing with mental health than others. So I think tying it all together, unfortunately, it's not a good time for prevention in our state, but we will carry on. Thank you for your help. We appreciate all that you do.
Thank you, Steve.
All right, next we have Richard. Your line is open. Please go ahead.
Can you hear me?
We can, Richard.
All right. I support the universal screening. My only concern and confusing is if a student is identified with disability, he or she would be screened through special education. So they would do the screening to determine the diagnosis and the eligibility for special education services. Secondly, my concern with universal screening, the special ed will take advantage, allowing this to be paid for instead of using their resources. School district do this. It's all politics and money. That's my concern. I can see that pattern of school districts choosing not to pay for it out of their resources and utilizing this to pay for the screening when it comes to mental health. That's all I have to say. Thank you. Oh, and Prop 1 is a mixed baggage. It will have negative effect of programs and services that are currently be funded that won't be funded in 2026. Peer services programs will be eliminated or reduced significantly because there will be no funding to pay for it. Our mental health community needs our peers to be able to help with their recovery. This is what it's all about, recovery. The Department of Healthcare Services, the Department of Health and Human Services have not answered any of my questions during the last year in regards to peer workers and the peer workforce with CalAIM. And it's obviously we were excluded. They're focusing on community health workers instead of the peer support specialist workers. Why is the state investing 5,000 peer workers when we have no movement, no support, no recognition, no respect from the state agencies and including us? They can't say that they were exclusive when they were not inclusive. They excluded peer workers like myself and not answering
Thank you, Richard.
questions.
Your time is up. Please wrap up your comment.
So the Oversight Commission needs to be careful in regards to Proposition 1. It's more psychiatric beds than supportive housing. It's a major loophole. Counties will get less money if Proposition 1 passes. Programs will go away if Proposition 1 passes because of the buckets we will lose. Thank you.
Thank you, Richard.
Okay, our final public comment is Laurel. Your line is open. Please go ahead.
Hello, this is Laurel Ben Hamida again. I'm still with Muslim American Society Social Services Foundation and RIMCO. I'm outside right now, but I'm listening. I actually made public comment at a committee meeting about this proposal, and I'll repeat the essence of that, which is with hundreds of thousands, probably over 1 million children in the California public school system whose home language is not English, and a lot are not Spanish speaking either. You must have instruments suitable for young children that have been normed on young children from those language families of origin if you're going to get this off the ground. Have you made plans to do that? Thank you.
Thank you, Laurel.
And that was our last public comment.
Thank you, Lester. Now that public comment has concluded at this time, and we have a motion and a second, Maureen, I'm going to ask that you please take roll.
I believe we are just one short of a quorum. Oh, okay. All right. Commissioner Bontrager?
Aye.
Commissioner Brown? Commissioner Bunch?
Aye.
Commissioner Carnavale?
Aye.
Commissioner Carrillo? Commissioner Chambers?
Aye.
Commissioner Chen? Commissioner Cortese? Commissioner Danovich? Commissioner Gordon? Commissioner Mitchell? Commissioner Robinson?
Approved.
Commissioner Rolette?
Aye.
Vice Chair Alvarez?
Aye.
Chair Madrigal-Weiss?
Approve.
All right, the motion carries.
Thank you, Maureen. Kaylee, thank you. We look forward to Phase 2 and hearing you come back to us. For agenda item number 9, the commission will hear a proposal for the use of funding to leverage improvements in full-service partnerships and will also consider a proposal to use Mental Health Student Services Act funding to advance best practice in school mental health. Executive Director Toby Ewing and Ryan Kopchak, Chief of Community Engagement and Grants, will present an opportunity to consider approval of an outline and authorization for commission staff to enter into contracts to release $25 million of Mental Health Student Services Act funding. As a reminder, funding for these grants were made available by the MHSSA Senate Bill 75 Statutes of 2019 and Senate Bill 129 Statutes of 2021. This request for application for MHSSA funding will be the 4th round of funding issued by the commission. Please go ahead, Toby and Ryan.
All right, thank you very much, Madam Chair. I think our team is going to put some additional slides up for you. We really have two pieces on this agenda item as outlined in the chair's comments. One is about funding to strengthen our full-service partnership work. We're not asking you to approve the expenditure of the funds at this time. We're asking for clarification and guidance so we can develop that proposal. I'll be presenting that. Ryan will be making a more specific ask and using some of the Mental Health Student Services Act funds that are still available to us. Throughout the day today, and consistent with the conversation yesterday, we really designed this conversation to lay out an understanding of the number of Californians who are coming into contact with state hospital programs, with some particular emphasis on persons who are deemed incompetent to stand trial. As we've shared with you in the past on the slide that's in front of you, we've laid out this logic model where we recognize that folks who are unhoused, who are justice involved, and hospitalized often miss many opportunities. As Dr. Sharon said, IST is an inconsistent or an incompetent service delivery system. He said that better than I did. But we have pointed out that full service partnerships are designed to be sort of the last step of a safety net that, as originally designed, was intended to prevent homelessness, incarceration, and hospitalization. Upstream from that are opportunities for better early intervention, particularly around early psychosis. You've made investments in that area. The commission and the state have made investments in youth drop-in strategies, including some recently released funds through the Child and Youth Behavioral Health Initiative. And of course, even more upstream is our school mental health work. The conversations around universal screening are designed to begin to do that, population level foundational work so we can understand the challenges that are out there. If you could go to the next slide. In each of these domains of our work, we've been working to ensure that the system design is aligned around outcomes. And so you heard some of the comments today in the panel about how Our fiscal strategies for full-service partnerships are aligned more with drawing down federal reimbursement than outcomes. We're actually putting together a panel for you later in the year to put some more detail there. That's in response to a legislative requirement that we report to the legislature on progress in strengthening full-service partnership programs. Currently, we recognize that there is a very high level of need for full-service partnerships, and these programs are not as successful as we'd like to see. Someone asked me earlier today, how do we know? High numbers of people who are living on the streets with serious mental illness and substance use disorder needs, high levels of people who are on waiting lists for treatment, as we heard yesterday and some of the comments today, and then high level of justice involvement for folks who are cycling through these systems. I don't have the numbers in front of me. We're spending at least $2 billion a year to run our state hospital programs. And so this logic model of strengthening full-service partnerships as an effective intervention to prevent folks living on the street, to reduce unnecessary hospitalizations where we can intervene better and faster, and to prevent justice involvement can and should be a priority. That's the premise under that earlier graphic that we showed. What we're asking today is permission or direction, so if you can go to the next slide, to develop a technical assistance and investment proposal using $20 million of Mental Health Wellness Act funding. It would be future funding that would really help us look at the key pieces that are necessary to strengthen full-service partnerships. Again, the ask today is just permission to move forward with this effort. It's not a proposal for spending, but it is to highlight the opportunity that you have. The focus that we have put together at the moment is to ensure that our funding models are outcome-based, as was discussed earlier, that we have a technical assistance strategy so that we can consistently and persistently get better at care delivery through the model, that we've developed the right way to gather data to understand what's working and what's not working, and the costs and consequences of failure through things like better matching of data between full-service partnership programs and justice involvement, making sure that our workforce is appropriate for the service in terms of the vision, the recovery model, that there are peers as part of that, that the workforce is reflective of the demographics of the population we're serving, so that we can ensure that care is culturally and linguistic competency. And this fifth one on this slide, that we're really building out public understanding and trust. And that's something we're just beginning to talk about as we get smarter and as we listen better, particularly around this idea that individuals and families understand what a full-service partnership is and have some shared expectations of what the outcome is, so that we can leverage those shared expectations in ways to keep attention on the idea that they'll actually work. So, our ask today, if you can go to the next slide, happy to answer any questions, would be for us to set aside, again, we're not entering into contracts at the moment, but we want to recognize that under current law, counties are required to set aside the majority of their CSS funds for full-service partnerships. Prop 1 would make some changes there, but they would be minimal in that FSPs would continue to be a primary investment requirement for county behavioral health programs. And so the ask is for us to come back to you in a couple of months with a detailed proposal that would build upon the conversations yesterday, the conversations today, and some conversations that we're hoping to put in front of you, I believe in April, with a detailed proposal for use of these funds. It's May.
Commissioner Rolette, please.
The team is just confusing me over there. Thank you, team. Apologies.
I'll move it.
Thank you, Commissioner Rolette.
I'll second.
I have a question.
We have a motion to approve the ask and a second, and we have A question, sorry, from Vice Chair Alvarez.
Toby, can you just remind us how this relates to the Mental Health Wellness Act priorities we already identified? Meaning early childhood, substance disorder, and there was one more, and older population, and there was one more.
So the commission identified a range of priorities, some of which we have already made investments in. The ones that are remaining are 0 to 5 and peer respite.
Oh, peer respite, that's what it was.
That's right. And we are asking you to add this to the list for consideration. Right now, we still have to work out the math relative to the funds we have and when they become available. And so our ask here is again, to add this to your list. As warranted is the argument based on the conversations we had yesterday and today. And our attempt is to do that in a way that doesn't distract from the timing to make good on the direction we got from you on 0 to 5 and peer respite. We have funded $20 million for older adults. We have funded $20 million for reducing unnecessary hospital boarding in the hallways with the empath program. So we have addressed the other priorities that you've laid out, but 0 to 5 and peer respite we have not. The challenges with those two are related to our intent to do it in a way that builds off of and is consistent with the funds that have recently been released through CYBHI and the funds that that could be available to support peer respite. We have some more homework to do on that. That's part of the reason why we're not asking you to fund this today. We're checking in with you to see if this warrants that level of investment so we can come back to you with that ask. And my intent is that we will be able to give you the ask on each of those at the same time. That would be easier if it was May than April. But thank you for the question, Commissioner.
Please, Commissioner Robinson.
Thank you. One quick question, just for my edification. You said this is not a it's not a funding request, but it can differentiate between funding requests and set aside, please.
Simply that we are, we're asking you if it makes sense for us to do the work to give you the proposal.
Okay.
Yeah, because the commission has identified a series of priorities that we identified probably a year ago, maybe 2 years ago. Older adults, reducing delays in hospital bed boarding. I think there was a third that we've already invested in, and then 0 to 5, SUD, that's right, SUD. So there's SUD contracts are being developed now, and so you've awarded in those 3 areas. The 2 areas that we have not yet awarded in is 0 to 5 and peer respite. And so what we're putting on the table is this recognition that as we looked at the model that we laid out for you, we recognize that we have made comparable investments in school mental health, in youth drop-in, in early psychosis, but we haven't done that on full service partnerships. And so there's some inconsistency between the sort of priorities that the commission has been discussing for several years. And so we had this aha moment of funds are flowing for FSPs, and there's a profound need for this investment. Can we do this in a way that doesn't distract from the other 2 priorities that the commission has already identified? And so the ask is, we believe that makes sense, but that's your judgment.
Can you clarify, what's the specific motion?
Simply to set this aside.
Oh, that's right.
That's right. And we'll come back to you at a later date for a specific ask.
Any other questions or comments from commissioners? Okay, I see none at this time, so I am going to ask that at this time, members of the public may request to make a public comment on agenda. Sorry, I'm going to stop that, and we are going to move on to Ryan's presentation.
Thank you, Chair, Madrigal Weiss, Vice Chair Alvarez, and Commissioners. I'd rather everyone do their comment now at the end of Toby's presentation but I understand. Okay. So my presentation here today is about the next funding focus and an RFA outline for the MHSSA funds that are available. And it's the remaining funds that we have available. So, Cody, could you advance? Thank you. So, just a general reminder that in 2019, Senate Bill 75 established the Mental Health Student Services Act to establish mental health partnerships between county mental health or behavioral health departments and educational entities. This slide is also in your packet. The goals here to strengthen partnerships, prevent mental illness from becoming severe and disabling, improve access to care, providing outreach, reducing stigma, and preventing negative outcomes such as suicide, incarceration, school failure. This is particularly relevant to our work with students. And during our research here, we were told that students are exposed to mental health services, terminology, and environments through their school-based mental health services, and reduces the stigma and aids them in being more likely to seek mental health services as adults. So we are actually getting feedback from them that's showing that this approach is working. Okay. Next slide, please. So the real value in what we've been doing, there is a summary of our community engagement efforts in your packet, but I did want to highlight it. So we surveyed in 2023 our MHSSA grantees and asked how they would use the additional funding they have left to meet, school-based mental health needs. 36 grantees responded, and then we followed up with a poll. And so the results of that poll were 50% of counties surveyed mentioned a need for additional staff or personnel. And I don't think that's a novel idea to anyone. I think everywhere across the board, we know that we need more people to help provide services. Workforce capacity was ranked first in the polls, with 27% of the grantees listing it as their highest priority. 80% of counties surveyed indicated a desire to enhance their services for marginalized and vulnerable youth specifically. Services for marginalized and vulnerable youth was ranked second in poll results, behind workforce capacity, and those go hand in hand. They want to be able to serve these populations, but they don't have the staff to do it. Sustainability is an increasing concern, as there are grantees who are nearing the end of their grant, and they want to know how they can continue on with these services. And then grantees are increasingly asking for an expert in sustainability, so like a statewide leader, something to that effect relative to future funding opportunities. Okay. Next slide, Cody. Thank you. So on January 9th, we held a listening session. What was unique about this listening session is we specifically wanted to hear from students. So we did a Zoom session and invited all of the grantees to host listening parties where their students could ask questions. And we got really great feedback from the students themselves. We had statewide, I think as in Northern California all the way to Southern California, across the board, we had over 50 students in attendance, and they were giving great feedback. Some of the key takeaways from that was a need for sustainability. What really hit home for me was the students, the teachers, everyone that was there, everybody said the same thing. If you take away these services, it is going to be detrimental to our culture. And it would be devastating to their school environments. So I think that was kind of what hit home for most of us. We also heard them, saying they really wanted peer support services. So expanding access to, funding for, and availability of peer support resources as an avenue of increasing student buy-in, adding to the workforce, bolstering services, and providing training education to students. The students themselves really see the value in the peer support services. We did talk about underserved populations and unnamed groups. Many vulnerable populations were identified, and specifically, we asked them to think of themselves and their friends or kids that they knew that they thought would need services, and their groups are not being reached, and how we could do that. One of the most poignant things I think that we heard was sometimes a kid doesn't fit into a traditionally what we would think of as an underserved group. And one of the ones that came up was like, someone mentioned that they had friends that were athletes and the tremendous amount of pressure that they were under. but they're not, considered a vulnerable population, and so they weren't getting services, but they would never ask for themselves. They also talked about scholars in the same way, right? So these kids, high achieving, but they're really stressed out about all the pressure they're putting on themselves or they're getting from somewhere else. So we thought that that was interesting feedback. We heard from adult participants about universal screening, and everyone agreed that it's, a great idea, but they just don't know how to get there. And we talked about like providing a roadmap or an implementation guide to that, and everyone there thought that was a great idea. The students themselves thought participation in universal screening was a great idea, and that they thought that everyone would have buy-in on that. Logistics were a concern. So space and time for wellness centers. Some students mentioned that they're limited to 15 minutes in their wellness center, and then they're asked to go back to class. And that was a huge concern for them. In all of the research that we have done, not once has anyone ever said that, our services are underutilized. We don't really need anything, right? They were begging for more, asking how they could sustain them. And everyone needs more help, resources. And that message is that, I think the message of mental health as health is getting out, and these kids are ready for it. And they want to continue to live that throughout their lifetime. So next slide, Cody. Thank you. So after all the surveys, the meetings, the listening sessions, we determined that the approach I'm going to present here is the best approach to focus efforts that make an immediate and lasting impact on sustainable school-based mental health services. So these approaches provide an avenue to addressing a large section of the continuum of care for students, including prevention, identification of risk factors, treatment, and program sustainability. In this RFA, we are really attempting to prioritize geographic diversity relative to size, demographics, and other nuanced population characteristics, prioritize marginalized, vulnerable, and underserved populations, and it just really kind of get as much help as possible out there. Next slide, Cody. So this proposed $25 million expenditure is a little different than the first three phases of MHSSA funding. So those were very open-ended and allowed for a lot of interpretation on how funds could be used. So this phase is more focused directly towards critical need areas. So what we're asking for is a total of $5 million for 10 grants of $500,000 to provide support services that may include peer support and student mentoring services to marginalized and vulnerable populations, such as foster youth, juvenile justice-involved youth, and other unnamed populations. Secondly, $8 million for 10 grants of $800,000 in funds to develop a plan to implement equitable and universal screening in schools. The grants will be awarded to 2 very small counties, 2 small counties, 2 medium counties, and 2 large counties. Efforts should include consideration to socioeconomically disadvantaged students. And I think actually those numbers were updated. So it would be 2 small, 2 very small, 3 medium, and 3 large. I apologize for that. We're going to tie this into what Kaylee was speaking about earlier, about the legislature's project for universal screening, and we would use this opportunity for the projects to inform each other. So things that we learned in building this implementation guide and this roadmap could be used to inform the commission's report mandated by the legislature. $9 million for 20 grants of $450,000 to support continuous quality improvement and long-term sustainability of school-county partnerships to support services. Funding could be used to hire a staff member to focus on sustainability, capacity, and champion the continuation of services. Finally, $3 million to support grants for other priorities as identified by nuanced populations. Examples would be building wellness centers, or like in rural communities, mobile crisis services, substance use disorder prevention, and psychoeducation. Next slide, Cody, thank you. So the proposed motion is as follows. The commission authorizes staff to initiate a competitive bid process and award $25 million in grants to the highest scoring applicants to advance best practices in school-based mental health. And that's it.
Thank you, Ryan. I was going back through the slides, so thank you. I appreciate that. So at this time, I'm going to ask if there are any questions or comments from fellow commissioners.
I have a quick question.
Yes, please.
Does this have to flow through county behavioral health? Because a number of our schools have done big work to try to create their own infrastructure where possible. And so it's through a partnership with the LEAs that they can do that.
And that's
Right.
required in the act.
The law requires a partnership that is the county behavioral health, LEAs, county office of education, and/or charter schools. How it actually flows can be determined by the partnership, but in other words,
So as long as the county behavioral health is the lead.
they don't actually have to be the lead, but they have to consent.
Okay,
Right.
thank you.
Other questions or comments? Please, Commissioner Robinson.
A little bit more detail on how the universal screening request ties in with what Kaylee presented earlier.
Sure. So in that ask from the legislature, we were asked to identify strategies, tools, resources, triage, and referral services, also training programs, technical assistance, cost estimates, legal considerations. So while that project is ongoing, this provides us the opportunity for the actual grantees to collect some of that data and help us focus our efforts in order to inform that report.
Commissioner, let me just frame that out a little bit. There's a lot of work happening in the universal screening space. There are individual schools and districts that have been in this space for a decade. The tension in the legislature is around establishing statewide strategies and creating some consistency across the board, particularly as they struggle with the issues around liability and parental consent. What they're asking of the commission is for guidance on sort of what's out there, as opposed to direction of how to do it, which is why it's literature review, some examples, why our team has organized site visits to places where they've been doing screening. Simultaneously, the school mental health community has said they want to learn more and want to get engaged. And so we see an opportunity to align this because our local partners and students have said this is something we need to learn more about. And so that can happen locally without legislative direction. And so it really is a question of, can we keep the ball moving forward at the local side while giving guidance to the legislature for some state-level conversations? But your point, your recognition that should we wait before we've done our homework? The reality is screening is happening all over the state. It's just happening in really, diverse ways. And this allows us to begin to learn more about how we might bring some uniformity to the strategy.
Thank you.
And if I could just add, just because we work on this project, my understanding too from those listening sessions was that because it's happening in some communities, there are some communities who are doing universal screening. They're saying it requires adequate services, and they would like to pilot following the recommendations of the report and to have additional services available, and also following the guidance of the report, start small. So if they could take it into a school community and demonstrate the effectiveness of it, and then contract for services or hire additional staff to meet the needs that might come out of the screenings, then they can really demonstrate to their school communities, to their boards, what it would look like. And I think it's the fear factor that holds the LEAs back from doing universal screening. But if they were to take those recommendations, start small, show that it is manageable, with funding like this, they would be able to build up that capacity to do it. So that's how I interpreted that from the listening sessions.
Thank you.
Is that accurate? Yes. Thank you. Okay. Please, Commissioner, Vice Chair Matabatis.
I have a comment and one question, Ryan. One of my comments is, building on Commissioner Robinson's comments and the chair's comments, just the opportunity really to connect dots across initiatives and conversations that are happening, particularly in light of the Children and Youth Behavioral Health Initiative, Prop 1. There's a lot of conversations happening, and it seems that we're having separate conversations and not always the legislature isn't always getting like the complete picture. And maybe this is a comment for Kendra, but is there an opportunity for a legislative briefing that helps explain the incredible work that's happening through MHSSA? You've done 2 rounds of funding. This is a 3rd round of funding now, right? There's a lot of investment in school mental health. Like, is that happening? Is there an opportunity to educate more of the legislature around that? Because it does feel very piecemeal when we're like, we're gonna drop some money here, we're gonna drop some money there, and it's like, what exactly are we getting out of that? And how is that woven into the broader strategy that's happening in order to reform these systems that we're all, on the same page about? So that's comment, question, however you want to interpret it. And then one question is, could you be a bit more specific on how this differs from those 2 rounds? Because we got a huge second investment to add in more schools on the MHSSA. And now this is another 25 million. Again, I'm not opposed to giving more resources to schools. They're incredible and believe in whole child approaches in school campuses. But it does seem a little piecemeal, and I'd be interested in hearing how it all fits together.
Thank you, Commissioner.
Toby, before you respond, and she was a lot more eloquent than I was. I mean, that's the feel. It's kind of piecemeal, and I guess in your comments, it'd be good to talk about, how are we learning from what we're doing? I mean, are there iterations where we're learning from the disparate pieces and taking those learnings and improving on the product? That's kind of, thank you for the comments, Vice Chair, because I think it helped to clarify my question a little bit better. Thank you.
Well, with that, I think Ryan should answer the question now. So, I think it's accurate to say that when we started this with a simple $20 million investment that is now ballooned to several hundred million, not to mention the 4.7 in CYBHI and community schools dollars. There's a lot of money out there, and it feels a little bit like we're sort of, what'd you say, dropping dollars here and there, in part because that is what is happening. And there's reasons for that in terms of the way funds are allocated and timelines that we have in terms of needing to use them. At the same time, it's not as haphazard as it might feel, in that there is learning going on. And part of Ryan's presentation is we stepped back and asked our partners what would be most helpful. And this is what they said would be most helpful. And we want to recognize that the burden is on the local partners to do the integration across the fee schedule of CYBHI, new accountability requirements that would be imposed with Prop 1 if that passes, the funds that we're providing, which is why we spent time listening and engaging and saying, we don't want to overwhelm you with just new dollars that would start something new. What would be most helpful? And that's what really drove this. At the same time, we have been investing in multi-county learning collaboratives in different areas around finance, around data, around youth engagement. We've also been, as you may recall, we've been talking with the governor and the legislature about putting in place the organizational leadership to move away from this, very broad brush approach of a lot of money quickly to more consistent, systematic investments in what we know works. Again, consistent with our strategic plan, that is, how do we promote strategies that we know work, and how do we learn what works when we don't know what works? Kendra's going to talk a little bit about our effort to establish an Office of School Mental Health in order to bring that kind of leadership. This is a very difficult time to do that because of the deficit. So the best I can say is all parties involved, locally, Department of Education, Department of Healthcare Services, the Commission, the Governor, CYBHI team, recognize that we need to move from the let's try something where we started, which is where this commission started, to what do we know about what works and how do we create systems to support our LEAs and their behavioral health partners, both county and non-county, to be successful in supporting students. These dollars are a step in that direction. Again, responding to what the locals had said would be most helpful. But your concerns are valid, and we are worried about that too.
Ryan, for you, not Toby. I am curious, Ryan. You guys did the listening sessions. So you said 50 students. Was that for this round? I mean, just go into why such a low number? I mean, it sounds like a decent number, but was that all of North, South? Because I think students have a lot to say. So adults are making decisions for them, but we need to hear really, I would say, from a broad range of students, what do they need? What are they looking for? So.
Yeah, no, I appreciate that. So we didn't know if we were going to get 3 students because it was an after-school time because we couldn't do it when they were in school. And so what we did was we invited our grantees to have like listening session parties. And so 50 was what we could actually visualize on the screen and count. But there may have been 20 kids in a room that we just couldn't quantify. And right, so there may have been more. But those 50 gave us a really great feedback, and they were as far north as Tulare County, or Tehama County, and all the way down to San Diego County. So it did represent large counties, small counties, rural counties, you know. So we did feel that that was a great group. But in addition to that, the commission has been holding a series of K-12 advocacy events. And so far, we've gone to Fresno, Sacramento, and Humboldt. And we've had kids from those areas come in, and we've had about 50 kids at each of those so far. Our final one is this weekend in San Bernardino. And so we're getting the same feedback from that group of kids as well, and they're all kind of saying the same thing, and you know, I feel like it's important that we listen to them. Yeah.
And then my last question, you know me, you know it's coming. Do you know what the demographic breakdown was?
Of the kids in attendance?
Of the students, yeah.
Because we did it on Zoom, I didn't have a full visual of all of them. I can tell you multiple ethnicities were represented. We had, gosh, I wish I could think of the organization that, but we had a full organization that represented Muslim students even, and we had a group of Pakistani kids that came as part of their group. So unfortunately, I don't have specific numbers just because we weren't able to physically quantify that. But there were many different ethnicities, cultures.
Okay,
right.
I'm just going forward, can we please try to make sure that we're getting that
Gathering that data.
representation and ask the question, and if the schools can't provide it, I get it if it's a rural area, but we're going to Fresno, San Bernardino, we should have a little bit of everybody, because
Yeah.
we need to hear from everybody.
We also, and I'm looking at Tom, we did a survey to accompany the meeting. So we asked them to go back to their schools and ask people to take the survey. And we did collect data on grade and age. I'm not sure, I can't remember whether or not we did, but I will check and see if we asked, you know, relative to diversity. But in the future, it is noted, and we will include that question in all of our surveys for you.
Okay.
Yeah,
Thank you, Ms. Ryan. You
absolutely.
answered that question.
thank you.
Can I just also make a statement? I want to be also clear to Commissioner Mitchell, these are not responses from the students. Okay, but I didn't, because I think originally we said it's 50 students, and I think this was pointed out, and I'm like, I just want to be clear that these are not, students aren't responding, okay. But I do agree that we need to know, you know, the demographics of the students that we are getting information from. I think that's very important. So I'm going to move us forward because we're going to lose our quorum, and we still need to hear from our community. So please, I'm going to limit comments to 2 minutes. At this time, members of the public may request to make a public comment on agenda item 9 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Are there any public comments, Lester? Please raise your hand now as the queue will be closing, and we will limit those public comments to 2 minutes. Lester?
Chair, we have 2 public comments. One in the room, Stacy Hiramoto. Please go ahead.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I thank Commissioner Mitchell and Commissioner Alvarez for the comments and questions because that took care of some of mine. it's hard for me to speak totally in favor or not on this motion because there are these two different items, the FSP and then the school. The presentation on the school, the school that was just made, I really appreciate the attention and the specificity, at least mentioning underserved communities, BIPOC and LGBTQ is what we usually look for. But, you know, services for marginalized and vulnerable youth, you know, I keep coming back and saying this because it is true. Whenever I talk to the people I work with, believe it or not, they say, you know, our parents and our students don't always feel comfortable at the school. And so in both, I would really appreciate if there could be some attention to partnering with CBOs that serve, you know, about BIPOC and LGBTQ communities in conjunction, not just the counties and schools. They're not going to solve, you know, the safety net is not there. The safety net is really at the local level with the smaller CBOs, and if they can be partnered with in any way. And I'm less comfortable, though, with the FSP because, you know, again, I've not been able to find the data on disparities on FSPs. And in the beginning, I know that FSPs were not serving communities of color nearly in the proportion that they should. And I know I should research this, but I haven't, but then it's not mentioned. So I just hope that there could be more attention and
Thank you, Stacy. Your time is up. Please wrap up.
to those two populations specifically in these proposals and the RFPs. Thank you.
Thank you, Stacy.
Great. Next, we have Graciela. Your line is open. Please go ahead.
Oh, thank you very much. This message is for Executive Director, Mr. Toby Ewen. Please read the documents that are emailed you. Maureen Phelan, a friend of a family, also visited my daughter at Napa. Maureen also emailed you some information. The documents that we sent were emailed to the address, once again, that appears on page 5 of your agenda. The information that is in that box that it says our commitment to transparency. If that's not the right email address, I would like to get it right now, or I can give you my phone number so someone can contact me.
Graciela, that is the email. Thank you for sending it. So the staff will get back to you. Thank you.
Thank you very much for all the information. I really appreciate you.
Thank you.
Chair, we have one more public comment. Richard Gallo, your line is open. Please go ahead.
Can you hear me?
We can hear you, Richard. Please go ahead.
Okay. I just have a concern with the FSP. I believe that I don't know whether it's in the contract or not to make a requirement to have peer workers as in the FSP. And I believe it should be and needs to be across all members of the community with lived experience. Secondly, whether do you have established data collection that needs to be utilized with the SP programs as a standard using tool in order to correct accurate data information that you need? It seems like the data collection issue has just been going on for way too long. It needs to end. It's ridiculous. It can be fixed. I remember making a recommendation to the Oversight Commission to look at Centers for Independent Living, CILs, how they do their data collection that the SP can use in order to, and build on that the commission needs. And it needs to be across the board with all contracted grants that the counties are getting from the commission, even though I know they do not want it. They don't want it, but it needs to be. Thank you.
Thank you, Richard.
And that was our last public comment.
Thank you, Lester. Now that the public comment has closed, I would entertain two separate motions. The first motion is regarding the full-service partnerships. The commission authorizes a set-aside of $20 million of Mental Health Wellness Act funding to strengthen full-service partnerships and asks staff to present a funding proposal at a future meeting. I want to say that this motion was made. Thank you. Commissioner Rolette made the motion. Commissioner Carnevale seconded that motion. We have a motion and a second. I would ask Maureen if you would please take the vote.
Yes. Commissioner Bontrager.
Aye.
Commissioner Brown. Commissioner Bunch.
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich. Commissioner Gordon. Commissioner Mitchell.
Yes.
Commissioner Robinson.
Aye.
Commissioner Rolette.
Yes.
Vice Chair Alvarez.
I think this might be out of order, but this isn't authorizing the set aside, it's authorizing the proposal.
Yes.
So we're not locked into.
No.
Okay, just want to make that clear for the record. Aye.
Was that a yes?
Yes.
Oh. Chair Madrigal-Weiss.
Approve.
All right. The motion passes.
Thank you, Maureen.
I just want to make a comment to your point. I already voted. I'm not trying to backtrack. I don't know what the law is. But the way it reads, and I'm not the best reader, I'd say, but it did to me read like we were approving a set aside in addition to a proposal. Is that incorrect? Because I thought it was both, like set
not-
aside and do a proposal. So no, it was just the proposal.
Set aside. It was just a set aside, not the proposal to spend.
Okay, so to set aside the money.
Set aside.
Okay.
Yeah? Okay. Now I would like to entertain a second motion around the Mental Health Student Services Act. The commission authorizes staff to initiate a competitive bid process and award $25 million in grants to the highest scoring applicants to advance best practices in school-based mental health. I would ask for a motion.
So moved.
Yes, we already did public comment. Thank you, Commissioner Carnevale. And do I have a second? Commissioner Robinson seconds. No questions or comments from my fellow commissioners. I would ask then that Maureen please take the vote.
Yes. Commissioner Bontrager.
Aye.
Commissioner Brown. Commissioner Bunch.
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich. Commissioner Gordon. Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Rolette.
Approved.
Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Approved.
The motion carries.
Thank you. All right, I understand that we have 3 of our fellow commissioners that have to leave at this time, so there are no other motions to vote on? No vote. So thank you so much. We are going to go ahead and move on. You?
Very important.
All right, next we will move on to agenda item number 10. The commission will hear a presentation on budget and legislative priorities for 2024 as it relates to behavioral health. We will now hear from Kendra Zoller, Legislative Deputy Director. Please go ahead with your presentation.
Okay, good afternoon, Kendra Zoller, Legislative Director for the Commission. My presentation, like the chair said, is to provide an update on the 3 proposals that the Commission wanted to pursue this year as sponsored bills. The last day to introduce legislation was last Friday, February 16th. There were a total of 2,124 bills introduced this session, which is actually down from last year. One of those bills is a commission-sponsored bill, Assembly Bill 2411 by Assemblymember and Commissioner Carrillo, co-authored by Senator Cortese and a fellow commissioner, so that they're doing that together, so that's great. This would require each county to have a local youth mental health board to advise both the county and the school districts on youth mental health policy. You'll recall the commission sponsored this bill in 2021, I believe, but it didn't make it because of the pandemic bill restrictions, so we're excited to introduce and pursue this effort again. Unfortunately, because of the budget deficit mostly, we were not able to get a bill on the Office of School Mental Health or the Workplace Mental Health Center of Excellence within the University of California. But the good news is the ideas in concept were met with positive feedback, and we plan to pursue other avenues to achieve their success. Our conversations with the legislature, the administration, and the University of California are going well and are ongoing. So the next step is for our sponsored bill, AB 2411, to pass its first policy committee, and we will begin building a support coalition as the bill gains momentum in the legislature. And that's my update. Happy to answer any questions.
Any questions for my fellow commissioners?
You mentioned, how many was it? 2,000?
2124, 2,124.
It wasn't 2,125? You sure? I'm just,
I'm like, I don't know.
Okay, see no other questions or comments. At this time, members of the public may request to make a public comment on agenda item 10 by clicking the raise hand button on your computer or the app, or if calling in by phone, pressing star 9. Are there any public comments, Lester?
Chair, we have no public comments.
Okay, thank you, Lester. Kendra, thank you for that presentation. We look forward to hearing from you more as the legislative budget season continues. I want to thank everyone for your participation and engagement in today's meeting. We look forward to seeing you all at our March 28th meeting at the Commission's headquarters in Sacramento. Thank you. Today's meeting is adjourned.
Thank you, Chair.
Thank you.